and I'm very sure that everyone is familiar with the anatomy of the foramen, but it is just for to revise our anatomy, and which is the key topic for today workshops. And we have certain workshops like transforaminal injection, T-leaf, and certain other procedures which are related to the transforamen. So basically, each foramen, there are foramens are situated on each side of the vertebral column. These are the gateway or the doors through which the certain structures pass in between the spinal canal and the outside. So if you look into the anatomy of the foramen, it is superiorly bonded by the pedicle above and inferiorly by the pedicle below, and posteriorly it is bonded by the articular facets, and interiorly it is bonded by the intervertebral disc and the end plates of the vertebra and the end plates of the vertebra below. These are the contents of the foramen, and we can appreciate here the spinal nerve, the radicular artery, and the radicular veins. And these are the veins that later on we will discuss. These veins which communicate the internal plexus with the outside of the plexus of the spinal column. If we look into the structure of the nerve, each nerve is formed by the anterior spinal root and the posterior spinal root. These two roots just unite at the outside, just at the border of the foramen to form a spinal nerve. And this is the spinal ganglia, and this spinal ganglia is just situated in the foramen. This is some brief description of the spinal nerve, and we could appreciate that the spinal nerves formed by the anterior and posterior spinal roots, they join to form a spinal nerve, and each spinal nerve then divides into anterior ramus and the posterior ramus. The anterior ramus later on supplies the structures of the adjacent levels, or they supply the contribute into the lumbar plexus or the sacral plexus, or in the thoracic region they supply the intercostal muscles and certain other structures. Now we will discuss the blood supply of the spinal roots and the blood supply to the spinal cord. As we know, in the thorax and the lumbar region, these the supply are from the abdominal aorta through the segmental arteries. These segmental arteries, after rising from the aorta, they divides into the segmental branch, which then divides into the posterior trunk and into the spinal trunk, which then divides, arises to a radicular artery that supplies the anterior and posterior spinal roots. This is some more clear picture of the blood supply. As we can appreciate, the artery arises from the abdominal aorta, and it then divides into a spinal branch, which then divides, gives rise to branches into the vertebral body and into a radicular artery that again divides into anterior and posterior radicular arteries that supply the anterior and spinal nerve roots, and later on they contribute into the supply of the spinal cord. There is some difference between the supply in the thoracic region and in the lumbar region. In the thoracic region, the intercostal artery divides into a posterior branch and an anterior branch. This posterior branch divides into a radicular artery and the posterior branch, while in the lumbar region, the segmental branch directly divides into a posterior branch and into a radicular artery. Again, this is some the main focus of this slide is about the diameter of the radicular artery. The radicular diameter of the radicular artery is between from 0.2 mm up to 2 mm. This knowledge should be everyone should know the knowledge of this diameter, because while inserting the needle more than this diameter, it could leads to damage to this radicular artery. This is the overall look of the blood supply of the spinal cord, and we could see most of the radicular arteries, they don't contribute to the blood supply to the spinal cord, but at certain locations such as at D12 and D11 level and D8, D9 level, and at level of the T1 level, these radicular arteries must be preserved, because they supply to the they contribute to the supply of the spinal cord. And in case if we could these arteries are damaged, they could lead to ischemia of the cord. Generally, we can divide the blood supply of the spinal cord into anterior part and into posterior part. The anterior part is through the anterior spinal artery, which supplies the anterior 2/3 of the spinal cord, while the two posterolateral veins, they supply arteries supplies the posterior 1/3 of the spinal cord. The venous drainage of the spinal cord and the spinal nerves in the form of venous plexus. So we it is divided into interior external venous plexus, interior internal venous plexus, posterior internal and venous plexus, and posterior external venous plexus. And if we see at this picture, there are this the venous drainage of the spinal cord is through the anterior part and posterior part. The anterior part is through the anterior median vein, the anterior anterolateral median veins, and the posterior part is through the posterior median vein and the posterolateral median veins. These veins then form a radicular vein, which then drains in through these venous plexus into the vena cava. Now I will describe some brief anatomy of the Cambrian triangles, which is the key topic for today workshops. Basically, in 1972, Cambrians introduced the endoscopic intervertebral discectomy. And if we basically, it is a right triangle over the dorsolateral disc space. If you could see, this space is situated at the dorsolateral aspect of the intervertebral disc. The boundaries, the hypotenuse is formed by the exciting nerve roots, and the base is formed by the end plates of the vertebra below, while the height of the triangle is formed by the traversing root or the dura. While approaching this triangle through needle, in posterolateral oblique view, this needle should be in the inferior 1/3 of the foramen, while on the interior view, this needle should not cross the mid pedicular line. Otherwise, it will lead to damage to the dura or the nerve roots. So I hope you this my talk should briefly summarize the anatomy, and thank you. This is the end of my topic.
Thank you so much.
Thank you.
Any questions from the participants of the conference? Everything is okay. Well, in that case, we can go ahead with the next talk. I was said that Professor Luis Borba will present the next talk.
Iman?
Yeah, that's what I was said. No? Okay. Yes, I see it's over there. If you just put your, or do you want me to download it to a pen drive or something? I can just connect my laptop. Okay. So next speaker, Professor Luis Borba. We don't need to present him. Everybody knows Professor Borba. Okay.
And yesterday, many residents and young neurosurgeons asked me, why do neurosurgery? Why you want to continue neurosurgery? Now everybody's fighting, everybody, and the specialty is going down. I go to dermatology. I go to another kind of thing. Why spend 6 years training? Why stay 10 hours in the OR? I come from very long. My city is here in the state of Paraná. Brazil is very large, divided in 5 areas. This is the Amazon. Okay? There's no way to destroy the Amazon. Okay? It's larger than France and Germany together. See? The news that you see sometimes. This is the area where the food is coming to the world. 25% of the soy, the whole world comes from this area. This part is colonized by more European. Here in the Northeast, you have several states. My cities are large, not so large, have 3 million inhabitants. It's a good developed thing. But we'll talk about neurosurgery. See? For us, and the medical student, and the resident, when you see the first aneurysm clipping, first meningioma has come out, I want to be a neurosurgeon. It's make the difference to us. As I said, I saw the first day, have a case that coming in the wheelchair. You do the surgery, remove the tumor, and the patient go home, walking. Sometimes you spend 18 hours in surgery. You are very tired. You go to surgery, take the tumor out. You can see there in the anatomy that it was almost impossible to understand and difficult to see if there is plain or not. You can see all the nerves after 18 hours in the OR. And the patient can recover in your mission and post-op. You can learn that to do neurosurgery is like navigating through the channels of Venetian. If you use the arachnoid, as Professor Vladimir showed, you can go around and play with several structures as this big aneurysm. You can go and dissect and clip. When you are young, you think that you know everything. But the time is showing that you have to prove. And more older you get, more you know, less you know. It's important to this that you are learning in every single day. There is no specialty if you need more death. You need dedication, determination, need focus, but it's passion that you do. There is no specialty that you can wake up in the morning to do a simple case and come back with a very bad result, and sometimes the patient death. You have the life of the patient in your hand, because you need to prepare yourself. You need to open your mind for many new techniques that are coming. The neurosurgery is not dying, the neurosurgery is changing. It's completely different. Just saw an article, a guy, I think he's from Africa, and a guy from Latin America together. Oh, neurosurgery is dying. Now it's endovascular. Now it's radiosurgery. No, it's neurosurgery. The other way to treat. if you believe that radio surgery is not neurosurgery, you give this specialty to another guy, with radiation oncology. The same thing happened with endovascular. It's a different way to see the same specialty. But we need to understand and learn that not everything that you hear, what you read, is the reality. In the judgment to treat the patient is extremely important. And you need to know that to improve in the specialty, you need to take risk. If you don't take risks, you got your goals. That is part of our specialty. We need somebody to follow. We need a mentor. We need someone to guide you. But when you are young, you can go to everywhere. You are a little bit lost or completely lost. If somebody can guide you, does not mean that he's the best surgeon in the world, but he can be the best man that can guide you. It's make a real difference. We need to define priorities in life. In neurosurgery can be not the most important, but can be one of the most important priority. One really want to be a neurosurgeon. You cannot be a neurosurgeon doing 30 hours, 4 hours per week. Neurosurgery is 24 hours per day. It's 7 days of a week. It's important. This dedication does not mean you cannot go to party, cannot to go to drink, cannot to go to, of course you can leave. But the neurosurgery can best be part of one of our priority. We need people to help you. And you need to be happy. Cannot be a guy that go to the OR complaining the whole day. Oh, this case is difficult. I have to stay the whole day here. Cannot do neurosurgery. Oh, this is terrible. I want to go home. You need to enjoy. If you don't enjoy your job, change. Go to the business. You may make more money. If your goal is to make more money, maybe go to another thing. This I showed the first day, my first 24. Education today, see, you need a good education program. What is the good education program? We have a plan. In the first year resident, the second year resident, the third year resident, you need to plan. This way you can go the evolution of your idea. Today, the knowledge is universal. The pandemic showed to us that you can have all facilities. We have the best man in the world, the best doctor in the world, the best neurosurgeon in the world at your living room, on your TV. And you can learn with him during all this time. And nobody you determine your future. You can determine your future. Nobody can do for you. Nobody do the surgery for you. Nobody will study for you. It depends on you. Today you have online, on-site, hands-on, all types of training. The webinar, as I said, changed the history of education. But this contact, the on-site meeting, is very important to exchange experience, that you learn a lot with the people, with direct contact. We are humans. This contact is very important to us. Not only for relationship, but to learning this is extremely important. We need to learn that the guy that is far away. See, a lot of people today said, oh, you don't need to learn temporal bone. You don't need Petros's approach. I can do everything for his small bore hole here, his small bore hole here. But there is a crazy guy. I don't know if he's crazy or not. He's in China. He has 1,546 petroclimal meningioma. In more than 50%, he used Petros's approach. And somebody now is coming with 10, 4, or 5 cases. You don't need. I think this guy has some experience. You need to understand and learn with these people. And not close your mind like this. You have to open mind. The many possibilities that is coming. We need to go and watch. Today you can see a 3D video at home with VR glass. You take your iPhone or Samsung, whatever one, you put in front of the VR. Somebody can be doing surgery in the other continent. You can see the surgery by YouTube online on 3D. That you can go to the place, as you have there, you have auditorium, you can transmit from the OR and the people can watch there. But this is the most important message. Every this thing that I'm talking crazily, don't forget this. There is no possibility in today's world of learning in the head of somebody. You cannot learn microsurgery in the patient. You have to prepare yourself before go there. It's like the war. You cannot take the gun and go like that. You need a strategy. You need to prepare yourself. And there are several ways to do it. The anatomical lab, go there, then do hands-on cadaver dissection is the ideal scenario. But this is 3 days course, 4 days course. It does not mean that you go there and learn a crazy skull-based approach or come from the nose from here to here. You do in the weekend, in Monday morning, you are in the OR doing the surgery. It's not that. It's just to open your mind and give you the idea. Everybody want to have like this, the cadaver dissection that I was in Little Rock this time. I spent almost 1 week to do this dissection, step by step. After you learn, you can reproduce. But you ask, oh, I don't have here his very nice and clean cadaver that I inject red and blue and the picture is beautiful. Okay, this here is to give lecture. This here is to save patient and save lives. This is the cadaver, old one, the same one that you have in every department, anatomy department. It smell bad? Yes. You can clean, you can wash, you can do anything. It's not the same. This is smell like good? Yes. It's different preparation. But here, I am preparing for one thing. Here, I'm preparing to save lives. In every anatomy department, you have the gold mine. That's the cadaver. Depends just on you. I don't have drill, but you have Walmart. You can go there and buy the small drill that is difficult to dissect. Of course, it's more difficult, but you have time, you learn. This is the cadaver, a boot model. You know, the guy from Syria, here, very poor country that's in the war. He had the idea. He put the pump in the cadaver and inject and make like a aneurysm, very similar. And upsurgeon, that this model that today is expensive. I think the price will go down. You can do this at home. Of course, you don't have the same skills, but you learn how to manage the instrument. You learn how to manage the loop of the microscope. This you can do everywhere. Don't need cadaver dissection. You can have lab like that, but you don't need all this facility as you have there in Brazil. You can use the placenta model. It's vascular? No, it's the placenta. See, it's pulsating here. You see, it's pulsating. It's a small pump. It's like that. You can prepare a placenta. What is placenta? How many placenta? How many people? How many deliveries per day in Karachi? How many go to understand there? You can go, can train. This is a 3D print. We do the skull in 3D print. You don't need the real skull. The idea is to give the depth. You put the placenta deep, looks like a Sylvian fissure. You can do and open the Sylvian fissure in surgery. You can open the Sylvian fissure very similar in the placenta. Injecting, you see. Don't need silicone tube. Oh, it's cheap. $50 cheap. $50 cheap for them, not for us. See, if each tube is $10, $15, $20, if each silk is $10, $15, $20, $100, it's money. And this you can get in everywhere, just what you want to do. This you can do injection, you can inject the placenta. This here is a filter, fluorescein. You know how much is this? $20. You can make this hole in the 3D print and take the small thing and put in front of your microscope. Now you have fluorescein. You don't need the crazy Kinevo, the crazy Leica, you have all this thing. It's very simple, just if you want to do it. Neurosurgery, we need to understand the anatomy. We need to understand approach. What kind of approach? Sometimes you need, sometimes you don't need. Interoperating neuronavigation, endoscopy, everything you can have. Everything is good, but they're not fundamental. Today, the MRI, the CT scan can plan to you the pre-op. You can see the vascular, you can see venous, you can fuse, but this is preparation. Cannot happen today in the world that the guy see the case 6 o'clock in the morning, 7 o'clock in the morning, and go to surgery at 8. See the MRI in the ward and say, okay, let's do that without any planning. We need to study, we need to prepare. See, we need to reconstruct. We use all the facility that machine gives to you. Sometimes you have, sometimes you don't have. You cannot believe in everything that is right. You cannot believe, have to be a critical, and judgment is very important. Not mean that somebody coming with a nice suit or coming from a very well-developed country that is completely right. Sometimes he's saying different things. His reality is completely different than ours. How the guy that do a tumor like this can teach me to do a tumor like that he never saw in his life. Our reality is different because this exchange between us, we have the same problem, the same situation. We have the experience, the change among us, between us. To finish, we need mentorship. We need somebody to help you. See, he's Professor Yashalgil. Believe it or not, it's me. He's Glenn Pate, who was the lab in Little Rock in 1995. Professor Yashalgil was going every day to the lab. Sometimes he took me the cadaver. I was very upset with him because I want to dissect, and he was coming there. He said, "Oh, let's do," and he sit in the microscope and said, "Oh, I want to do, sir." No. I want to stay 1 hour, 2 hours. But I was learning a lot of that man. Make me completely different. But it's the last message. I'm talking too much here. Who likes football? You remember like that. This guy, his name is Romário, Brazilian forward. 1994, he won the World Cup in US, almost alone. The Brazilian team was very bad. It was 10 guys that just touched the ball, and he was doing all the things. He never trained. He hates to train. He was just for the game. And this guy here down, Cristiano Ronaldo. If you see the video of Cristiano Ronaldo, 17 years old, you say, this guy cannot be a football player. What's the difference of Cristiano Ronaldo and Romário? Cristiano Ronaldo trained 24 hours per day. He's living training. Now he's Cristiano Ronaldo, one of the best in the history. This guy, the talent was given by God. This guy, he built his own talent. He's built his own. We can be Cristiano Ronaldo. Few people will be Romário, but all of us can be Cristiano Ronaldo. Our future depends just what you do, what you want to do. It's make the real difference. Thank you very much, and sorry for the distraction. Thank you.
As you said, Salman, it was amazing and very motivational. Thank you so much, Professor Borba. Any comments? Any questions?
No question.
I got just recently a medical student, and he comes to me and he says, "I want to be a neurosurgeon." And I says, "Why you want to become a neurosurgeon?" He says, "Because I'm competitive." And then he smirks and he says, and because the other competitive sports need just one ball. I liked him so much. The next speaker. So the next speaker is Muhammad Farouk, who's going to talk to us about transforaminal surgery under local anesthesia.
Bismillahirrahmanirrahim. Assalamu alaikum to everyone. First of all, I would like to thank Professor Salman Sharif and his great team for arranging such a wonderful conference and letting me be a part of it. My topic is transforaminal endoscopic discectomy under local anesthesia. I am Dr. Farooq Sherzada, working as a neurosurgeon and endoscopic spine surgeon at Afridi Medical Complex, Peshawar. I started my endoscopic spine career in the year 2017 at Peshawar, and 2019 and 20% of my cases were full endoscopic spine surgeries and 80% open. While in 2021 and 2022, 60% of my cases were full endoscopic spine surgery and rest are open. Among that 60%, 70% is interlaminar approach and 30% is transforaminal approach. So here is a brief history of a discectomy, the first surgery done by Maxter and Barr in 1932. Then the first interlaminar extradural approach to lumbar disc prolapse was described by Lowe and Walsh in 1938. Then the Yasser Gill, who introduced the per-operative microscope and called it a microdiscectomy, and still it is a gold standard. Then Kasper in 1977 introduced his own technique and reduced the size of the incision further to 5 centimeters. Microdiscectomy was further refined in early 1990s by McCullough. So about the history of endoscopic surgery, transforaminal endoscopic surgery was first introduced by Hijikata and Yamagishi in 1975. Then Parvez Kambin, who further developed this technique and defined the anatomical landmark for a safe entry zone. Then Anthony Young, who developed a young endoscopic spine surgery system, work under constant irrigation. In late 1990s, Rutin et al. Work on interlaminar discectomies. In late 2000, Kim et al. Further work on over-the-top decompression for a spinal stenosis. So the aim of endoscopic spine surgery is to provide a safe and targeted access to a compressive pathology with a minimal soft tissue trauma while performing decompression and or fusion. And it contains the 3 main components. One is endoscope, which provides clear visualization, working channel to deliver energy for coagulation, and tools to retrieve and loose fragment, and irrigation system. This is constant inflow and outflow. So you all know that low back pain is significant and common. Why? Because 75% adult will experience it and 7% become chronic. 90% resolves in 6 weeks. And it is the second most common reason for medical visits. And it is #1 cause of work-related disability worldwide. If you look at the causes of the low back pain, so majority is due to a non-specific low back pain, the rest is due to disc herniation, stenosis, facet arthropathy, fracture, ankylosing spondylitis, trauma, and etc. So how do we treat this? Medical management, pain management, and surgery. So the medical management, conservative management include oral medication, physical therapy, and epidural steroid injections. As you all know that epidural scarring is the most common cause of failed back surgery. So, and it is the natural healing process followed by a spine surgery, but it is frequently associated with failed back surgery syndrome. Aside from contributing to poor surgical outcome, epidural fibrosis leads to increased complication rates in revision spine surgeries. And also multifidus plays a very important role in providing stiffness, stability, and support to the spinal column. Endoscopic spine surgery proves to cause less damage as it is minimal invasive, hence securing the multifidus muscle, resulting in less chance of instability. Initially, it was thought that the sun is revolving around the world, but then a European scientist proposed a theory that the earth is around the sun and it is a paradigm shift. Initially, it was thought that a big surgeon will give a big incision, but now a big surgeon will give a small incision. The most important for a transforaminal surgery is this slide. Previous campaign introduced the anatomical understanding of a safe zone where you can reach to the disc without violating the surrounding structure. And it is called Cambian triangle. It is anteriorly bordered by exiting nerve root, inferior bordered by end plate of the lower vertebra, posteriorly bordered by SAP of lower vertebra, and medially bordered by traversing nerve root. And its approximately height is 12 mm, width 18, and depth 22. And when we introduce the endoscope, it is 8 mm. So we can safely introduce the endoscope to the disc through a transforaminal approach. So these are the indications everyone knows, especially for a beginner, short duration of history, unilateral distribution of pain, young to middle age, no severe comorbidities, radiating pain along with tingling, exclusion for beginners are old age, long duration, motor deficit, cardia equina. Radiographic investigations, unilateral paracentral protrusion, contain disc herniation, L4, 5 and 3 for more preferable. For a beginners, L5 S1 level can be done if patient had a low iliac crest. The exclusion for a transforaminal, scoliotic or kyphotic deformity, patient with fibrocalcified disc, high iliac crest, patient with infection or metastasis, spondylolisthesis, and instability. For endoscopic spine surgery, we need a special instrument. The first one is endoscope, which is 4.1 mm working channel endoscope, and a special instrument that is 2.5 to 4 mm, which include disc removal forceps, Carrison punch, Penfield dissector, flavum annular cutter. We also need a radio frequency cautery to coagulate the things. And we need a burr for bony work. This is a usual setup for endoscopic spine surgery. The surgeon is standing on the side of pathology while the irrigation on the top and the C-arm and the monitor camera on the opposite side. Local anesthesia with conscious sedation is more preferable for transforaminal surgery. No general anesthesia, epidural or spinal anesthesia. Is introduction of endoscopic in a Cambian's triangle, having exiting nerve root very near by, so chances of injury may be more if general anesthesia given. I regularly prefer local anesthesia, infiltration from skin, subcutaneous tissue, muscle up to the lateral border of the facet joint. No local anesthesia use at foramina. So preoperative MRI assessment is very important to determine the angle of trajectory for a safe entry to the disc. So we have 3 approaches for a transforaminal. One is posterior, one is posterior lateral, and the third is the lateral. And it depends on the location of a disc herniation. If the disc herniation is paracentral, so you can do a posterior lateral approach. If the disc herniation is far lateral, or it is foraminal or extraforaminal, then posterior approach. And if the disc herniation is central, so you can do a lateral approach. So for a lateral approach, and also your entry point depend on the pathological factors that I said, disc location, patient factor. It's maybe in a higher BMI, the entry point may be a little far. In anatomical factors, on the upper lumbar spine, maybe it is near to the midline, while in the lower lumbar, it is far away from the midline. For a lateral approach, the angle is 15 degree. For a posterior lateral approach, the angle is 25 to 30 degree. And for a posterior approach, that is for upper lumbar or foraminal and extraforaminal, it is 45 to 60 degree. The pre-operative planning is very important. It's just like you want to put this ball in the basket. You know the height, you know the distance. If you are good in calculation, then you can put this ball in the court. And if your calculation is good, so you can achieve your goal. If preoperative assessment is not enough, then it may harm the patient. So position of the patient is prone, bolster under the chest and the pelvis to make the abdomen free, and a little bit we tilt the table to decrease the lordosis and to open off the foramina. The most important thing is calculating the entry point. So as you can see in this picture, this is a midline, which is called a spinous process line or line 1. And this is a discal line, line B. And this is the posterior facetal line. So this is for central disc herniation. You need these 3 lines. And why I draw this line? Because here is iliac crest. So with the AP image, I draw another line to introduce my cannula easily without touching the iliac crest to the foramina. And the other thing is, for posterior lateral approach, we need again 3 lines. The first line is spinous process line. The second line is discal line. And the third line is disc inclination line. So if you draw this line, the disc inclination line, so this is basically for the entry point. This is the distance from the midline to the entry point. Ahmad, video nahi ho raha? Video. Video play nahi ho rahi? Take it. So as you can see in this images, this is the first line, midline. Then this is the discal line. This is the second line. And I did this. This is a rehab surgery, initially done by open approach. And this is the third line. This is disc inclination line. This is the distance from the interior of the vertebral body up to the skin surface. And this measurement is for your basic entry point to the transforaminal approach. So once you have a basic entry point, then you introduce your cannula in the AP images up to the medial pedicular line on the AP image and confirm it on the lateral image up to the posterior vertebral line. And this is the landing point for your safe entry to the disc. Once you confirm your landing point, then slightly introduce your cannula into the disc and then do a discography. Confirm it on the AP as well as on the lateral image. So this is how I do a discography, 1 to 2 ml of Omnipeg, and to see either I am in the disc or not. Then I introduce the dilator again up to the medial pedicle line, because from medial to the medial pedicular line is the dural sac. So how I Then I hammer the dilator to anchor it in the foraminal. Then the working cannula. So when you are going to introduce the working cannula is basically a bevel shape. So initially, the bevel is facing upward. That is the tip. You hit the facet joint with the tip of the bevel. Once you hit the facet, then you rotate the cannula to protect the exiting nerve root. Just you can see, initially I put, and then after introducing the endoscope, you easily remove the disc fragment. So this is a short video in which I introduce anesthetize the skin, then introduce the guide wire cannula, then guide wire, then introduce the dilator, then anchor the dilator in the foramina, and then I introduce the working sheath over the dilator and then the endoscope. So this picture from the last conference, third Dr. Farooq International Endoscopic Spine Workshop with Dr. Tonch Coach from Turkey, and a huge disc fragment we removed on through a transforaminal approach. And Dr. Naeem Rahman is standing behind. So the conformation of decompression is free fluttering of annular flap and epidural fat, epidural oozing, visual confirmation of removal of entire herniation, relief of pain is confirmed by the patient, visualization of decompression traversing and exiting nerve root, and free pulsation of neurological tissue. And lastly, we put a soniplast over the incision. So this is article which shows that outcome of endoscopic discectomy compared with open microdiscectomy and tubular microdiscectomy for lumbar disc herniation, a meta-analysis published in Neurosurgical Spine Journal in 2019, and it shows that the incidence of dural tear is less in endoscopic surgery, while the length of stay is less and endoscopic, and return to work is faster, while the leg visual analog score and back is more good in endoscopic spine surgery, while the serum CPK and CRP marker is less in endoscopic surgery. Another article which shows the complication rate of different discectomies technique for symptomatic lumbar disc herniation, a systemic review and meta-analysis compared with open discectomy and microdiscectomy. Result of this meta-analysis suggests that PELD has a lower risk of overall complications and lower risk of complications necessitating conservative treatment. Another article, learning curve of full endoscopic discectomy, and conclude that transforaminal endoscopic surgery was steep and easy to learn, while the learning curve of the interlimb approach was flat and hard to master. Thank you.
Thank you, Dr. Farooq. Good presentation. Any questions?
No, this is basically a case done by someone else 3 years back.
Yeah.
In transforaminal surgery, up till now, I don't have any case which I repeated in last 1 or 2 years, because with good visualization, you can remove the disc as much as possible. You can see the exiting nerve root, you can see the traversing nerve root, and also due to local anesthesia, you can ask the patient to cuff. If there is a easily pulsation of the dura, it's mean that it's enough decompression. Yes, there are 3 approaches for a transforaminal. I told you that is lateral, a posterior lateral and posterior approach. For the central disc herniation, the approach is lateral. And it is, you draw a line on the lateral image, posterior facetal line, because interior to the facet is retroperitoneal area, and above that is the paraspinal muscle. So you can put your needle through a lateral approach and can remove the disc from the center of the disc. Yes. Yes, that was a central disc.
Assalamu alaikum. As every procedure has its pros and cons, what are the disadvantage of endoscopic discectomies as compared to other procedures?
If I talk about the transforaminal, so radiation is the most common, that is for a surgeon especially. And the second thing is the anatomy. If you have a good knowledge about the anatomy, especially the SAP, the pedicle, the traversing nerve root, exiting nerve root, and your preoperative planning is enough that you can see that there is no two nerve root on the MRI, there is no low-lying nerve root on the MRI. So I think it is too safe. And so far, I did more than 550 cases. We have only 6 patients for discitis. We reported 6 patients, no dural tear. So I think it is more safer because of visualization and a constant irrigation. And this is not a dry approach. This is basically no air contact with your disc level.
And what are the percentage of the recurrency?
So I told you that till date, I don't have any revision case for a transforaminal surgery. Maybe it take more time to have some type of complication to deal with.
I had a recent patient that I have operated. I operated her 2 years ago. She was a 47-year-old girl, but very fit. So I did L4, L5 transforaminal, and she was doing pretty well. I followed for a year and then I discharged her. Then she decided to go and climb Mount Everest. And she was doing it on her own with a big backpack. And then she climbed the Everest, but she came back with another disc. So I had to reoperate her. And I reoperated with classic open approach. And there was literally no scar tissue. That was just recently I did. So indeed, I think I have done, from my own cases, I've done 2 revisions distantly, and I see minimal or no scar tissue formation. In my first 50 cases, I had a few immediate revisions. I had to go back because I left. I think I had 2 cases. I had to go back and do open because I left fragment, but it's the first 50 cases.
I think the data you have presented is good. New techniques should be there and one should look into that. But I think if you look at the experience and the literature by those who have done probably in hundreds, maybe in thousands, microdiscectomy with a 3 centimeter skin incision and a very, very small and a very, very fine drilling, you can do a variety of recurrent, ruptured, subligamentous, far lateral discs. For a contained disc, maybe transforaminal would be, an approach one could adapt, and in patient choice of having under local anesthesia. But I think for a complex disc, which would be ruptured, chorda equina, it'll be very difficult to go through a transforaminal and look for those fragments. And also, I mean, when you're looking for, arachnoiditis, the adhesions, which sometimes are there, then I think the results probably, I don't know how you can compare the transforaminal cases with people who have done, a larger number. The numbers could be over 2 decades. We started with large incisions. It came down to small incision, endoscopic, midline, lateral. And I think if somebody can give you more than 95 to 98%, results, then I think it depends upon the choice of the surgeon and, of course, what the patient wants. If they just want that it should be only one, small nick there and you can pass an endoscope. So I think there are a variety of things that you have to look into when you are performing and offering the options of surgery and the treatment modalities. Thank you.
Well said, sir. Basically, endoscopic spine surgery has 2 approaches. One is interlaminar and the other is transforaminal. If we deal with the lumbar spine, so 70% of the pathology can be dealt with the interlaminar approach. And only 30% can be dealt with the transforaminal approach. So for complex pathology, so I did over the top decompression for a single level with the interlaminar approach full endoscopically, 2 level and a 3 level as well, because we have a case report will come in next September. And we did a 3 level over the top decompression for severe stenosis with the 2 7 mm incision. So you can deal with that. Only the thing is tumor removal through endoscope. It is a challenging. You can remove the disc. Either it is caudally migrated or it is cranially migrated through interlaminar approach. The transforaminal approach is only for paracentral disc herniation, or there is a lateral stenosis, or there is a far lateral herniation. So these 2 are different routes.
Yeah, I think this is very important what you've just said, because the message, because most of our youngsters who are sitting here, they should not be carried away by a small nick and a small incision, but you must know it. What is the end result of the surgery? And I think the timing of the surgery, I won't say mine, I think Naeem is sitting here, 45 minutes, 40 minutes. So I think my timing would be, but I'm not talking of my timing. We are talking of what the literature says. But fair enough, I think there is a place for transforaminal, and for contained disc, I would say you look at the MR very carefully, look at the symptoms very carefully, and then you make the offer to the patient, because it is also that what the patient wants. And then also you have to be very honest when you talk about the results of the surgery. So I would really appreciate the new techniques are coming in, but the message has to be loud and clear to the youngsters who would be operating in different setups. Thank you very much.
Thank you.
I don't know what, Peep thinks about it.
Well, I think that yes, it's a new technique. It's coming. It's becoming more and more popular. It is very popular in certain parts of the world. In other parts, it's just starting. Kim has been here so many times, and probably you know Kim from South Korea, from Seoul. If I remember, it was 2019 when I asked him, when did you do your last open surgery? And he said 4 years ago. So he does. So probably he has done now over 2,000 of these endoscopic cases, and he does these extensive approaches with interlaminar, and also with transforaminal. He can approach caudally and cranially migrated discs contralaterally. This is high pilotage. I cannot do that myself. I would not attempt to do that anytime soon. So in a way, your message is right. It's a good that we are all here to drive new things and new techniques. But yes, we have to be careful introducing them. We have to be first safe for our patients. We have to, especially with the first cases, we have to be very, very, very selective what we are doing. And then slowly, with the number of the cases, things are coming. And but you have to give time. You have to be patient. And remember, I showed you that steep learning curve. You need 50 50 cases, and then you're enthusiast. After that, you double your cases, you become a novice with 100 cases. And then after you double again, 200 cases, you start understanding the new techniques. So this is very valid for these minimal invasive techniques. So that's why the curve is very steep. So be careful. New techniques are important, and it is good for us to introduce them for our patients, and it's good to learn, but be very selective in the beginning, give time, and whatever is not possible today, the day after tomorrow will be possible for you, but give time and be careful. So you're right.
For my passion, looking for the new techniques. I went to Korea and Kim was there, and in one day they showed me. I said, no, I want to look at it, that what is the superiority, why I should be doing or why I should not be doing it. They did 7. In one day, we started 7 o'clock in the morning, and with Kim, and there was another colleague. He said, no, I don't do this. There's another colleague of mine. And in 4 theaters, they did 7. So I think what Baby is saying is very correct. You should be looking into it, but selective, and you have to categorize things, and the message has to be very clear that you know when to do it, what to do it, and how to do it. Thank you.
Okay. Thank you.
So I'll moderate myself while he's coming. You know, I'm presenting next. It's about how we use the X-ray with all these minimal invasive techniques that we are all talking about to you today. How to use it effectively, and more importantly, how to use it safely. Because,
Hello.
There is research that tells you that if you do minimal invasive, the X-ray use is more than if you don't do minimal invasive. There is research for everything. I don't think you need research to tell you that you will need more X-ray, but I have research. Yes.
My name is Dr. Ali. I'm from Peshawar,
Yeah. So it's just.
and I would like to ask from my senior, Sir Salman Sharif and others, that learning of the new technique is need of the day. And every 8 and every 10 patient ask about these techniques of endoscopic spine surgery, usually in our clinics. In our setup, we don't have any opportunity, particularly an opportunity to get a fellowship or training in endoscopic surgery. I think is not easy for everyone to go abroad and learn. And I request Salman Sharif and my seniors to kindly think for it, and if possible, should start fellowship in spine learning and endoscopic spine surgery in Pakistan. Thank you.
Yeah, so fellowship training is indeed a very important. It's an intense way to introduce and to learn to do a new technique. This is probably the best way to do a fellowship training. So the best way to introduce new technique is, as it was already said, you don't go to a course and then tomorrow you start doing the technique. Luis Borba said that, you don't just watch a few videos in YouTube and then tomorrow you start practicing on your patient. You would not be happy if your doctor does that to you. So in order to learn a new technique, especially if something very different from what you have done so far, yes, you have to read the literature first, and you have to watch the videos, then you have to go to a course. Then ideally you have to go to a fellowship, and then ideally for the first cases, you have to have a mentor that will be with you, and then you start on your own, and then you have to pace yourself, and you have to be very selective. You have to use initially very, very basic cases, and then slowly progress to new cases. This is the safest way to introduce something. But there is other ways. If you have previous experience, And if the new technique is not very much deviated from what you have done so far, if you manage to break the technique to a small tasks, which are something similar that you do, then probably you can introduce it without fellowship, but it's going to be slower.
So, as you know, we already have World Federation's fellowship in our hospital and in Lady Reading in Peshawar. We have been having fellows from various parts of the world who come here and train. People from Pakistan have come. Naeem has spent time with us as well. So the easy way is to go to a place where it's easily available. Yeah, I totally agree about what Tariq said, and again, what both of my friends said regarding how, where, and when you should do these procedures. I did 5 of these in a row. It was 4 years ago. Bobby was here, yeah, 4 years?
Was it? I don't know.
4 or 5 years ago.
Yeah.
So we did 5 of these, 4 of them recurred.
We were
And-
probably 2019.
Yeah, so I had to revise 4 of them and do open. And then I was talking to Kim and Lim, who do lots of these in a recent meeting in US. And both of them said, no. We used to have huge recurrences, but now our patients, we give them rest for first week. 7 days they rest, they only go to the washroom and back. And after 7 days, they're mobilizing them. And then they're saying there are no recurrences then. The problem is there is no pain when you're doing these surgeries. And if there's no pain, the person thinks, oh, I'm grand. So they start jumping, doing things that they shouldn't be doing. So for example, his patient is trying to go up the Everest. And if you do that with a big load on your back, then obviously you will have a recurrence. So,
Yeah.
But, these people went back, they were doing various things, but, out of the 5, 4 recurred. So I stopped doing them. So for example, Dagor in Cleveland, he started endoscopic discectomy and used that for a little while, and he saw huge recurrences in his cases. And he said, in my hands, just tubular surgery is better than anything else. So
But on the other hand, Mike Steinmetz is doing it, which is the same institution.
All I'm saying is that, whatever is in your hand is better. You should do that. You should learn and see. And yes, the reason Farooq and Nicolai are here, because I want to start again, because, there's so many patients come and say, you do everything, but why aren't you doing this one? So we have an easy go that we use for interlaminar, but, we also want to have in our armamentarium, various other things as well. It's nice to learn and try again and try Kim's and Lim's approach. I don't know what you do, but Kim and Lim are saying they're putting their patients 7 days only to the washroom and back.
I don't do that. First of all, I'm still selective of which cases I do endoscopic. I am not like Kim and Lim that everything is endoscopic. I still do, as you said, in my hands, tubular retractors and mini approach, over the top decompression. I still use these things and they work well for me. But there is cases which I would do endoscopic, and also there is demand for that. People are, as you said, asking. They come and ask you for endoscopic surgery, for minimal invasive surgery, for laser surgery, Star Wars, everything. So it's just like that. People are like that. They are asking for. They read in internet and they come and ask. Yeah, so you have to, if you want to keep the pace, you cannot ignore the new things which are coming. So you have to stay in touch with the new techniques coming. But yes, I completely agree with Tariq. You have to be selective, you have to be careful, and you have to know why you're introducing a new technique.
One thing that I would like to start, I think that this is the young man has said. I think many youngsters, they have they think that, the fellowship is an exit exam. It is not. Your actual training starts once you have got the license. Then you need to know that how you drive your vehicle on difficult terrain. So what you're talking about, a fellowship, in my talk, I emphasize that training with, top mentors, people who have 20 years plus, like Peeve and me, have been traveling together. And then I stopped traveling because I thought that now I've traveled enough. But I have been going still looking for knowledge. The new knowledge, the research is the new knowledge and a database. We need to collect that. And for you people, we have to create that environment where people like, Nikolai will come and they'll talk about different technique. And I think our young friend here, he's given a very good talk.
Yeah.
So I think you need to spend time and invest time to have the expertise and skills to become a leader in that area. Please start.
I agree with you. So you have to be selective. You have to be careful. You have to be responsible to your patients, and you have to not do something that you don't want somebody to do on you. You have local people. I don't know him. I met him just this time when I came here, but looks like he's very experienced. So you have people to learn from. So just carry on, just drive. Okay. So all these things that we do minimally invasive, we need a lot of X-rays, but X-ray is dangerous. So there is a lot of, I just learned last year about a friend of mine that from Turkey, who is endoscopic surgeon, who had a thyroid cancer. So I don't know if it's related, but he does a lot of endoscopic surgery. There is a lot of research to tell you that the spinal surgeons, they develop cataract quite early in their life. And you all know Greg Trost, he's been here many times. Greg Trost had cataract surgery recently. So yeah, so just be careful with the X-ray. And I personally, my approach to that is, in order not to be afraid of something, you have to know it. You have to learn about it, and you have to know how to deal with it, and then it's okay. So this is where I'm coming from. I told you about the research that says that the minimal invasive requires more X-ray. That's intuitive, but people do research for everything. So this is the spectrum of the different radiations. We have the waves, the radio waves. We have the visual light, and then we have the radiation, the ionizing radiation. So that's what we are afraid of, the ionizing radiation that has a lot of energy and that will harm you. So we have normally, human beings will receive radiation. There is a natural sources, like I'm coming here and I was flying 10 hours to come here. So I got some couple of X-rays because of that. This is what happens when you're up and you have radiation. So, but there is nowadays a bit of about 50% of the radiation that we are getting. We have now artificial sources of radiation, and about 95–96% of these artificial sources are medical sources. So be careful with radiation. So what we are afraid is, we are afraid of this type 1 and type 2, the scatter that happens when we're using X-rays. Well, of course, if you are straight on the beam, this is something that you will be afraid of. But if you are wise enough not to expose yourself right under the beam, then this is not dangerous. But this is what you're afraid of, the scatter. Again, this is the scatter. So the X-ray tube produces radiation. This is the beam. You normally are not afraid of that beam because you don't put your hands, you don't put your body parts under the beam. But what you're afraid is, you're afraid of this scatter that goes all around. So this is, you have to know how to keep yourself safe from the scatter. And very important thing, I think that was very interesting for me to understand, that if you have a fat patient, the scatter goes more. So you have to charge them more if they are fat, or you have to send them to lose weight. So this is, again, the different dosage that you will get depending on where is the tube and where is the source. So where is the tube and where is the image intensifier? So basically, If you are on the site of the source, the radiation dose is significantly higher. I will repeat that probably about 10 times during that talk. If you are on the site of the source, the radiation dose is higher. Don't stay on the site of the source. Don't stay on the site of the source, please. Yeah. So this is a distribution of the scatter depending on where you're staying. So see, this is a patient that you're operating. You need X-ray in AP position. That is quite common happening during the minimal invasive stuff. You do that like that interlaminar. You do that like that transforaminal. You do like that perk screws with C-arm. So if the source is, so you have to leave the source under the table, and then you have to use protective, obviously. So only then you are containing the scatter above the table. When the source is under the table is not as big unless you are without protective. And then the other thing important from that slide is when your AP, for example, here, look at what's happening. So this is very high dose, then the dose goes rapidly down. The scatter goes rapidly down only with 30 to 60 centimeters away from the body, from your object. So what you have to do, what is the point and what is the message from that slide is, if you're X-raying, if you're operating, you're X-raying, you don't hold the instrument. Try not to hold the instrument when you ask for X-ray. Leave the instrument, dock your Jamshidi needle, or somehow leave the instrument or use some long instrument and try to walk away from the patient. Even 30 centimeters walk away from the patient gives you significant drop of the radiation. And if you go 60 centimeters, your dose is 1/8 of what you will get. So walk away. And then again, this thing, what I told you is choose your site wisely. So if you're on the side of the tube, see what happens. The dose is significantly higher. So if you, for some surgery, have to stay right next to the patient and hold some instrument, at least don't hold the instrument on the side of the tube. Go on the other side. Okay, so go on the other side. Same thing here. This is showing you how the scatter is distributing if you put the tube wrongly. This is a wrong position of the tube. That if the tube is above the table and if you're doing APs, you're getting a lot of radiation. Your face is getting a lot of radiation because you will not have protective on your face. If you're using, you have to use LED glasses if you have, but that is something that you have to avoid on AP. This is the right position. This is the right position. And again, the same thing here. See, if you're on the side of the tube, if you're close to the patient, you're getting significantly higher amount of scatter comparing to if you're on the other side. So stay on the right side of the patient. Protective equipment is very important. I take that very, very seriously. In my practice, I use LED glasses. I use 0.35 lit equivalent, and I use double breasting. So in front, I have actually 0.7, which is good protection. So C-arm position, we said that. These are positions that you have to be very careful with. There is another slide about that. So so-called hostile positions of C-arm. When you're not true AP or true lateral, you're getting more scatter. So again, very important for you to be away from the tube, away from the source. Stay away from the source. Don't stay on the side of the source. The distance is very important. This is another slide that is demonstrating you that the distance is very important in your safeguarding. So if you're 3 meters away from the source, you practically can be without any protective gear. So distance is very important. Try to stay as far from the tube as possible. If you have a good X-ray technician, that will help you to reduce your radiation again. Collimation and giving you the right picture and not taking a lot of pictures until gets the right picture is very important. So it is good for you if you're doing like him many cases endoscopic, then probably is a good idea to have a radiographer that you will work on a regular basis, so they know what you want, they know how you operate, and they don't give you unnecessary and wasted X-rays. And also collimation. You have to play with the collimation. If you collimate, if you only X-ray the object that you need but not panoramic pictures, then you significantly reduce your dose. So this is very interesting research. You can see here the surgeon is using lead glove. The surgeon is using lead glove to hold an instrument, and that surgeon has a false feeling of safety because he has a lead glove, and that is exactly a false feeling of safety, and that is proven by that research. A Korean team, they have investigated and they have done the following experiment. So they got a detector of X-ray detector, they wrapped it on a lead glove and they put it right on the side of the patient. That is position A. And then they get the same detector and then they put it just 20 centimeters away from the 20 centimeters away from the patient, 20 centimeters. So the detector B got less radiation despite it was not wrapped in a lead glove comparing to detector A. So that is telling you again the same thing what I just told you. Even if you step one step backwards, your dose is getting way less, even if you are or without protective gear. So first lesson of that, don't hold the instrument, or if you hold it, you have to hold it with some long instrument. Ideally, don't hold it, try to dock it on the bone somehow. And when you're X-raying, try to step at least one step back. Before you say X-ray to your technician, try to step back at least one or ideally two steps. Okay, image acquisition technique, it is very important. This is the importance of your tech. The tech is going to help you to get the right images without X-raying quite a lot before. Quite often it happens if somebody is inexperienced, he will take 5 pictures before he gets you the right picture that you want, and that is bad for you because you get a lot of radiation. Same thing here. Okay, how we go about that? Experienced radiographer. If you have a good C-arm, the modern C-arms, they can remember the position, so you can go back to the same position. But even if you don't have a very modern C-arm, you can mark the floor, you can mark the C-arm, and like that you can reduce your dose. So surgical technique, we're going to talk. He spoke about this technique. It is important. Positioning is important as well. Biplanar awareness. I'm not going to talk about this. I'm going to talk about this later. So this is it. My take home. Distance is very important. Distance, stay away as much as possible from the source. 30 centimeters, 60 centimeters, whatever centimeters. Distance is your savior. Try to stay also on the safe side. Stay away from the source. Lead gloves, don't use lead gloves, because when you use lead gloves, you tend to go there and think that, oh, I'm protected, I'm using lead gloves. That is not the case. And we discussed image acquisition, surgical technique important, but that comes with time. Okay, so thank you so much. Questions? No questions.
I just made one comment.
Yes.
I think with the use of more and more instrumentations, the young doctors and our young trainees must know it that it is just like wearing a helmet or a seat belt. It is protective.
Yes.
So I think when you talk of being protective and keep that distance and to wear the right gear like the lead gowns and the neck gears, and sometime when you're using these glasses, when you're using the lasers, they're all protective equipment when you are in the theater. So I think it is just like wearing a seat belt or a helmet. So I would use that term. So be careful and be protective when you're using X-rays or radiation. So I think very informative talk, Piv. I think I must say, Nicolay, very informative. And these are small things, but they matter a lot. Thank you.
Thank you. Yeah, you're right. So if you're right, if you have a seat belt, but if you drive with 250 and if you crash the car, that's not going to save you. So you have to use it wisely.
Many slip between the cup and the lip.
Yes. Okay.
Can I ask a question? What about navigation? You mentioned navigation, neuro navigation.
Yeah, well, the navigation is good to have. If you have it, that's going to reduce your dose. With the endoscopic stuff that we are talking about today, I think JoyMax are trying to introduce navigation now.
Yes. RevoSpine and JoyMax both.
Yeah. So it is coming. It is coming just now. It is not widely available as yet. It's going to be a while before it is widely available. Even if you think about the navigation for screws, it is available already for what, 20 plus years. But it's still, I doubt whether all of you guys are having it and using it on your everyday practice. So you're going to be using X-ray now. You're going to be using X-ray in the future. As soon as you use it wisely, it's going to be safe.
Okay, thank you, Dr. Nicolay,
Thank
for
you.
a knowledgeable talk, how to protect from radiation during the surgery. So your next presentation are full endoscopic interlaminar approach.
Yeah, so the
technique.
next one is interlaminar approach. So let me see. Yeah, so the point with the plan was to give you, sorry, how can I start? Oh, okay. All right. Right. Okay. So I just wanted to start with a short classification, and then I will just crack on with some practical things. So full endoscopic discectomy. So basically, that table is telling you what we're talking about today. We're talking about that's the nomenclature. Full endoscopic discectomy, full endoscopic foraminotomy, and then depending on the site alongside the spine. So we have interlaminar, we have transforaminal. We spoke about transforaminal. We are going straight to interlaminar. So for the interlaminar approach, you use, unlike the transforaminal, where the knowledge that you need is completely different from what you're used to. For the interlaminar, you kind of use the same knowledge that you already are used to with the classical open approach. So again, you have to use that knowledge. You have to know where is the disc. You have to know where is the pedicle. What are the relations between the nerve roots and where are the discs. Where you have to look for the disc. You're gonna see it on MRI scan, but you have to know where to look about it. Usually this is the area, so roughly 1/3 will be right on the level, and then you will have caudally and cranially migrated, and then you will have a small amount which will be lateral. So usually when we do the interlaminar approach, we use that window here, the interlaminar window. When you are advanced, you start using drills. If you have migrated discs, you can drill and you can enlarge that window and you can achieve more. But in the beginning, you'll be using just that window. You have to understand the X-ray anatomy. So you have to appreciate the window that you have to go through. You have to do the measurements, and you have to know how the neural structures are projecting with relation to that window. And you have to know that usually the interlaminar window goes smaller as you go up. So as a rule, especially in the beginning when you're starting, the interlaminar approach for you will be L5S1, maybe L4, L5. And then if you would like to do transforaminal, probably transforaminal will not be a good idea for you if you're a beginner and if you want to go L5S1. L5S1, it is possible, transforaminal, but it's more difficult because you will have high iliac crest. If it's a man, it's very likely that you're not going to be possible to do L5S1. Sometimes you have quite big transverse process that will be blocking the access to the L5S1 transforaminal. So interlaminar will be your approach at L5S1 in the majority of the cases, especially in the beginning. L4, L5 also possible. The above levels, they're becoming more difficult, so you may consider transforaminal there. So this is sort of a planning that you have to do. That's the midline. The skin incision is right next to the midline, and it's usually less than 1 centimeter. And then the next thing is you have to plan your instrument. So after you do the incision, you do the incision. It's a good idea to do incision not only of the skin, but you stick your scalpel deeply, so you cut the fascia as well. Otherwise, it's very difficult to pierce that trocar through. And you have to align your trocar with the disc. The alignment is very important because you have done a very small incision. The skin is mobile, but if you don't do the right incision with the planning, you're going to be feeling in an awkward position. It's going to be more difficult for you to do the discectomy. And then after, so you can verify AP and lateral. On AP, you have to see that picture. You have to dock your tip right on that angle between the superior and the inferior articulating process, right on that V here, right on that V. This is where you're going to start working to explore and to open the yellow ligament. That's basically more or less similar thing with what you're doing when you're doing microscopic. So this is after you introduce your dilator, the next step is you're introducing your working cannula. And then you start, and then you introduce your scope. So when you introduce your scope, even if you have if you have docked yourself properly, that is what you see. You see on the top, you will see a little bit of a muscle, and then you will see the fat tissue that is overlaying the yellow ligament. So you have to remove that fat tissue with the instruments that you have, and you have to expose the yellow ligament. So this is medial, this is lateral, top and bottom, and this is the area where you have to start exploring and piercing the yellow ligament. So the next step will be you introduce one of these scissors that you have in the set, in every set endoscopic, and you start opening and piercing the yellow ligament. Once the yellow ligament is pierced, then you see here on that picture, medial, lateral, top, bottom, you have the yellow ligament opened, and you see the peridural fat tissue. The next step is you remove the peridural fat tissue with instruments or with coagulation, And then on that picture, you see already you have the yellow ligament, you have the peridural fat tissue, and you have, this is the peridural membrane that I have found here. Quite often you will see that peridural membrane that in the beginning, in my first cases, that was bugging me a lot because I was thinking, is that a peridural membrane or is that a dura that I'm going to pierce now? So you always think about that in the beginning, but as soon as you know that there is another membrane here, then you know what is that and you are not afraid. So once you open the peridural membrane, then you see now on that slide, so we have a few layers which are uncovered. You have the yellow ligament, then you have the fat tissue, and then you have the nerve root, and you have the central dura. That next picture is zoomed in. I already have entered the canal with the cannula. And so the next picture is you have this dissector, which you can start dissecting the nerve roots, and then you start removing the disc herniation. And it's that is in general the technique. It is difficult to be conveyed to you with a presentation only. You know, that's going to give you an idea of what is it about. You have to see it in a cadaveric lab, and you have to be with somebody to show it to you. In general, the approach and the anatomy is more familiar to you comparing to the transforaminal if you have done the classical transforaminal discs. This is the endoscopic surgeons are talking about generations of endoscopic surgery. So they consider the first, if you talk to Kim, he'll consider the transforaminal surgery as first generation full endoscopic surgery. This will be the second generation of full endoscopic surgery. The third generation full endoscopic surgery is when you start using the drill and you start doing not only discectomies, but you start doing different decompressions. And then the fourth generation is when you start doing endoscopic fusions, endoscopic TLIF. Okay, that's it. Thank you so much.
Thank you, Professor Nekule. Now, any question from audience?
Now? Okay. Okay. Shall we go on? Okay. And we do the interlaminar, yeah? So sorry, transforaminal, yeah. L4, L5 transforaminal, yeah. Okay. It's left-sided, yeah. I think it's left-sided. Okay.
Okay.
Let's get the basics. Yeah, 1 second. I'm just getting started. So it show live here from start perspective. How it goes in the whole steps, and you can ask questions, and thereby you can way that so you can that is how it could be. It just showed up the cases. What are the different cases? I mean, am I coming to your back? Yes, you are. It's only use fine. Yes. So, somebody should put a mic and then that is something.
Morning, everyone. So we have two spine cases and we'd go one by one and I would appreciate it to be interactive. So we would be discussing, but the plan would be like, what do you think your differentials would be on the basis of history? So we had a 36-year-old female, no known comorbs, presented to the clinic with complaints of classic lower back pain for last 7 months. The pain was radiating to the left leg till the ankle posteriorly. She had symptoms of claudication for 5 minutes and her sphincter control was intact. On examination, her powers were 5 on 5, reflexes were +2, and the SLR was restricted on the left side to 60 degrees. So now, on the basis of clinical examination and history, what would be your differentials? Anybody from the participants? Aruba, can you pass on the mic to the people on the back or here? Anybody?
As according to the history, if the power is normal and the pen is radiating to the leg and is straddling right, it is positive under 60. So it's more probably the problem in the lumbar region of the spine. We are our DDX will be first. It will be the disc problem, nerve root compression, maybe due to disc herniation or stenosis. And the other one is that's enough.
All right, so we have a giver for a disc. Why not stenosis? Anybody? Any takers?
In stenosis, usually the SLR is not restricted
All right.
and pain radiates on both sides.
All right, fair enough. And would there be any differentials on the basis of the fact that could you localize that? Would it be a far lateral disc or just paracentral or, foraminal disc, whatever, on the basis of the history? It's just, we're just doing it to make it interactive. So that your mind's all freshen up. It's just a little bit of brainstorming. There's no right and wrong here. We'd be following this with scans and x-rays. So this is just part of the interaction with.
If we talk about the foraminal disc, the pain should be very severe.
All right.
That's one, the pain should be very severe. In the claudications for the foraminal disc is not as much clear as in the stenosis or in the disc herniation that maybe in my thought it would be central or paracentral disc.
All right.
Into lateral or foraminal.
All right. So enough of the discussion, I suppose. So we'd have MRI. So that's an MRI of the same patient. Would anybody like to describe this? People on the back, please. For sure. Aruba, that row.
Actually, I cannot see.
You can come in the front because
But-
you have very less people. You can always come in the front. So come and sit in the front.
So here we can see the sagittal and the axial sections. On the sagittal sections due to variability, we can see disc dehydration at L5 S1 level as well as thicker second indentation at this level as well. So this is L5 S1 disc.
So Dr. you think it's L5 S1? Are you sure?
I mean, yes, It looks like, oh, sorry, it's L4, L5.
Yeah, thank
It's
you.
L4, L5.
So fair enough. That's a left-sided L4-5 disc herniation, rather a paracentral disc, which is obviously causing compression on both of the foramina. These are the X-rays. We have dynamic as well as the AP views. So from the faculty, what would be the plan? Sir, if you would like to enlighten, how should we approach it?
I think there are two rewarding surgeries in, operations in neurosurgery. I would say three. One is an extradural hematoma, which comes in good grade. You remove it and everybody says you are a great surgeon. And rightly so. Second one is, the benign meningiomas, or the ones who are, and they are cortical, even if they are anterior parafalcine, if you remove them, you do, a great job. And third one is a good disc that you can remove. I think the one of the youngsters yesterday, when I presented my talk on neurosurgical training program, he said, sir, if you can teach us 4 operations, we will be very happy with that. Maybe that is their outlook. But I would like that, all of you, my slogan is what one man can do, another man can do. What I can do, you can do it. So I think that should be your passion, and that should be the way you should be looking at it. You should be the number one, or you should be one of the top surgeons when you talk of being a neurosurgeon. I think coming back to this, this scenario, low back pain is one of the commonest disease that you come across in neurosurgery, in spine. And then when to treat seriously or take a patient of low back pain who comes to you when the pain becomes radicular. What is a radicular pain? The radicular pain is when it transgresses or it travels into your leg. I was just talking to Naeem. We were together for a very long time. And, I used to tell them, don't operate for low back pain. People unnecessarily operate for low back pain. That is bad. You need to see what is the, if you have a psychiatric patient, he'll keep on coming to you, doctor, I have a severe pain. You operate and you are stuck for your life. He will never leave you. And he can even take you to a place or the extreme area. You've got to be careful when you take a history and examine. So I think the initial history was that he's a young man. Stenosis is relatively less common in younger people. What is the commonest type of disease in your lumbar area? L4-5 and L5-S1 prolapsed intervertebral disc, or degenerative or spinal disease. Symptoms of spinal lesions or space-occupying lesion like ependymomas or intradural extramedullary lesions in that are still far less than prolapsed intervertebral disc. So the differential diagnosis is that it is most likely a degenerative or a spinal or a prolapsed intervertebral disc. Now, what is the first investigation? I would always go for a plain X-ray. Though in the exam, the examiner might ask you, no, doctor, you were talking of, 20 years back. Sometimes you find, spinal dysraphism. So there is something which patient has got back pain, and maybe that gave 1% of the people or 5% of the people with, spinal dysraphism, or patient who have got, a spinal deformity may develop, spinal back. And then, of course, is the one which, as I said to you, show the MR scan, please.
Disappointed.
I think one of the most important X-rays, zoom kare, Ahmad, zoom kare. Many people look at this thing. I look at these far lateral. What do you see here? What do you see here? That is the fat. You see how much it is being compressed. Look at the fat here, here, here. What is happening here? This is where the roots are exiting. But that is a very important area that you should be looking. Do not look at this MR because this shows a central disc. And if you look at the other, please show the other one, please. और जाइएगा उधर और दिखाएंगे. ये जरा इसको come. Yes, yes, please go ahead. Move it here. Yes, that's. And look here. What is happening? This is the disc which has prolapsed and the thecal sac is being compressed, and either side the nerve, more on probably on the right side, that this nerve is being compressed here. Less still there is a still nerve. You need to have the eye. I went specially to Cambridge to look into, the radiology of MR. I've been traveling extensively to learn and to get educated on things like, as I said yesterday, you cannot train your neurosurgical residents unless you have got a backup service. I am not a radiologist. I'm not a neuroradiologist. I need to have the expertise of somebody. Then he will say that there is a central disc, a thecal compression, and the exiting nerve roots on this side is completely obliterated. On this side, still I can see. Can you see that? Lights थोड़ी सी बंद कीजिएगा. And always see the MRs and X-rays or CT against a viewer. हमारी एक और आदत है कि हम X-ray यूं अपने ward के अंदर against the light. Please do not do that, because you will miss so many things. Look at this X-ray here. जरा lights बंद कीजिएगा. ये आपको nerve root नजर आ रही है, so they're here. But then if you look at the other cuts here, then you need to see, because for interlaminar or even for the translaminar, now people are going only from one side. I am very comfortable going from here up to the opposite side, especially if you have got endoscope, a 30-degree, you can go to the other side and you can remove the disc from other side. If you have got angle, rongos, you can remove that, but you really need to know that don't take the nerve from other side. So I think one need to learn to read the MR. And if you look at the MR, there is a, then you need to see where, on what side, and of course, the side of the pain, you operate on that side of the pain. It really doesn't matter that what is the, the procedures that you do. I'm not going to talk about my results, but I'm going to talk about what the literature says. The best option and the best procedure is where the end result is that the patient says, I'm 90% pain-free. Whether it is interlaminar, whether it is endoscopic, whether it is a microscopic, or whether it is a, translaminar. So I think you choose, an option where you are trained and you feel comfortable. But nowadays, patient will come to you and says, doctor, do you do endoscopic surgery? Then you have to explain to him that you do a minimal invasive surgery. Now the word used is MIS, that I do minimal invasive surgery. You will be up after 12 hours and you can walk around. If you tell this thing to the patient, they'll be very happy. The other important thing that I would like to ask you, and also I'd like to tell you, is when you would like to intervene. A patient comes to you with back pain, 2 weeks' time. Would you like to look at and get, carried away by this MRI scan? Or you tell him, no, take this medicine, go home, take rest, and after that, come back to me in 2 weeks' time. A patient comes to you, a young man, he's an executive or a doctor or an engineer, and he says, doctor, 3 months I have severe pain. I can't sit, I can't drive, I can walk. A lady says, I can't go for shopping. I can't stand there. I can't do the household work. 3 months she is in pain. So will you operate after 2 to 3 weeks, or will you operate on a patient who is, 3 months down the line after he has had all physio, analgesia and exercises and every type of, treatments, conservative treatment. So what is your, your selection of patients?
As per the research, sir, low back pain, more than 85% of the low back pain will subside within 3 months, even without medications. So my selection is that I will wait until 3 months or more. If that pain is relieved, so it's okay. Otherwise, I will go for the further investigation, MRI, and see what's the main reason. So I will search it more than 3 hours.
Everybody.
एक दे दें आप इनको भी. Everybody agrees that, 3 months is a cutoff time, that, you don't put the patient to more agony and then say, okay, fine, after 2.5 months or 2 months. But if the patient has got a neurological, he develops the sign, he develops something like a foot drop, or he has got difficulty in passing urine, or he has got a koina, then the sun should not set. There is a saying that, once patient comes to you, he says, Doc, look what is happening. I can't walk. I have a high stepping gait. He has developed a foot drop. Or do you have a problem in passing water? Yes, doctor, I have a difficulty in. Then you should get the patient into the theater immediately. So I think this is something, the baseline for operating or considering, surgery for these patients. I'm glad Asif is here. So we are welcome, Asim. So this is, that anything else
To follow.
Please, feel free. Last there info a mic.
Sir, as sir you said that patient with low back pain should never be operated until and unless they have neurological finding or feature of neuro compromise. We usually see patient and everyone is agree upon that that the patient with low back pain with no neurological feature of radiation or any neurodeficit should not be operated because they will not let you to see the other. He will come back again and again that I am not improved. We are agree, but I operated 2 patients of only low back pain with no radiation or no neurological compromise, but there was a huge disc herniated on the MR, and they compelled me to operate them. I was not agree to operate, but they compelled me to operate, and they are luckily improved. So I want to take just opinion as you people are senior, having a lot of experience, that should we operate such patient or not with significantly herniated disc and with only low back pain with no other feature?
I think I will take this statement very seriously. And the reason we are all sitting here is that you have to learn from the experience of the people who have traveled long distance in treating low back pain, prolapse disc. You never go by what the patients tell you. You make your own decision. I think with my practice, I can operate 5 patients a day, no problem. Because they come, you say, doctor, I've got severe back pain. Why there is a specialty like, the pain, patients who treat pain. And if you have 2 patients you operated, you were lucky enough to get away. But what about the number of patients who have got back pain and you operate on them? They will go in the market. They will say, Mr. So-and-so operated me. He says, did you have, leg pains? He said, no. So I think it is very important that, the low back pain should, unless he has got some other problem. Rheumatic disease, early malignancies, TB, they are all diseases where you should be looking into it. And you have to be very thorough when you examine them. And I think pain specialists, they give them certain, lumbar blocks, facet blocks, and epidural blocks. And I am now more convinced that, back pain should be treated by people who are pain specialists, not by you still have got a lot of things to do. So I think you got to be very careful when you choose your patient operating on that. It is just like, doing an angiography on patient who come to you with a chest pain. Ever since, I'm very sorry to say, the health card has come, at least in the place where I work, one hospital has done 1 billion rupees angiography. So please, as a professional, be intellectually very honest. And also, I mean, the patient will come and they'll pressurize you. Doctor, I have got pain. आपको समझ नहीं आ रही मेरी disease की. Doctor साहब, आप मुझे क्यों नहीं treat कर सकते? But you still have to be consistent, and you said, fine, be polite, but be firm. So no, you don't need surgery. You need to have physio, exercise, swimming, change your posture. What is the type of job you're doing? And but of course, if the MR shows something, drastically wrong, then you can always go for that. That I'm not denying. But as a rule of thumb, back pains are not to be operated. They can be sent to other area or look for some other cause of the back pain.
Sir, thank you for detailed description. Sir, sometimes patient comes to clinic with a foot drop, and that is because of the pain during dorsiflexion. So it's quite mimicking to the motor deficit, particularly when you see the in MRI, you see the L4, L5 disc on the same side. So what is your experience in such cases in which the patient is unable to do the dorsiflexion of the foot because of the pain, and you see the large disc on the L4, L5? So do you treat that conservatively or you go for surgery?
I think I made it very, very clear. We were talking about only exclusive back pains. And I said, when the patients become, they show signs, which is a foot drop, a sphincter problem, a quadriquina, or he has got more than 3 months of severe excruciating radicular pain. A foot drop is 100% an education, an indication for surgery. But be very careful. Tell patient that you have a foot drop for the last almost 4 weeks. I'm not very sure whether it's going to improve or not. Because the patient said, doctor, you operated me, my foot drop is still there. Because the time of improving the, the neurological, damage has gone. Now you're operating him for a further damage, sphincter to save the sphincters and to save the weakness on that. So I think these are quite a few things that you have to learn, which of course you learn with experience. Don't get moved away because you see some people, when we are young, we don't have many patients who comes for surgery. So anybody who comes in here, we just have this thing in mind. To be very honest, I have to be very honest with you. But what I'm saying is, when I was leaving my training center from Birmingham, I asked Professor Hitchcock, "Sir, is there anything that you want to tell me or advise me?" He says, "Yes, it takes 10 years to learn how to operate, but it takes another 10 years to learn when not to operate. So you must know when not to operate."
Thank you, sir. Sir, in cases of low back pain, no history of radiation into leg. But when we examine such patient in the background of a prolapsed disc, the straight leg raising test is significantly reduced. So is that indication for surgery?
Yes, I think there are a lot of scenarios that you have to discuss, and I'm very glad that you people asked me this question. I think you got to be, again, very careful. Read the MR very carefully. You got to see if the MR doesn't show any compressive side or a significant, and if the MR reports also says that there is a moderate herniation of the disc, please do not operate. Because there's so many people who come because of the pain, they have got restricted, straight leg raising. The straight leg raising is not an indication for surgery. But if the patient has got persistent pain, which is radicular, I'll again repeat, it goes into the radicular area and they have got other symptoms, then you should. Low back pain and straight leg raising is not a sign or indication for surgery, but be very careful when you look at the MR. Look at it many times, or you can repeat it. One more thing that you can ask for, because sometimes the inflammatory diseases do not appear on MR, on X-rays, you got to go for an isotope scan. So down the line, you still learn that there is a disease developing. A patient used to come to me. He was a chief executive, and he would come and he would talk to me in a very arrogant manner. But he would say, "Doctor, I think you don't understand what's my problem." So I was very polite with him, and with my gray hairs, still he could not, pressurize me, because he knew it that, it's not easy to get around with me. I said, "No, you don't need surgery." He said, "But Mr. A and Mr. B says that you need surgery." I said, "Okay, come to me." And after about 2 months, I said, "Okay, go and get an MR, this isotope scan." He said, "Should I go and get a PET scan?" Because now, the Google and the onlines and these things, they have, falsely educated, negatively educated patients in a manner that you have to come across. First they'll say, "Doctor, what type of surgery you'll do?" You will say, "I'll do a laminectomy." They'll take out a cut. "Will you do a foraminotomy or an endoscopic surgery or this thing?" But I think you stay cool. Don't get upset with that. Because you are sitting in a private sector and you're marketing. You got to be a good person to sell your skills and your knowledge. And so I think that gentleman, again, let me tell, and the report came to me, there are early signs that he has got marrow changes. And at the end of the day, that man had leukemia. And he still sends me, he's terminal, he still sends me a card almost every 2 or 3 months. So being so thankful that you did not get pressurized by me, and I was very, very unfair with you. So this is my message this is my second year of my practice. I celebrated 32 years in Faisalabad. I went to Faisalabad. One of my students, after being a professor, retired, and I gave a history when I came back from NYU, which was my last place where I was, working, doing my fellowship. So I think there's a lot of distance you have to travel when you learn.
All right. So that was a good and thorough discussion. We have a second case, and this is probably the case that we're operating today, this morning. So we'll just briefly go through the history, very brief input from the audience, because I know you guys would be bored and would want to head for the tea. So tea break is waiting for you guys. So it quickly go. There's a 34-year-old male who presented in the clinic with back pain for last 4 years. That had increased in intensity over last 1.5 months. He had left leg pain radiating down, and his sphincters again were intact. His examination had a left leg SLR that was restricted, and he had powers of left-sided EHL that was 4. Rest of the muscle groups were 5 on 5. So this is an MRI of the same patient, and wait. Would anybody like to read the scan? Okay, sir. Yeah.
Name something.
Here in both cases, you have mentioned that patients are coming with back pain. But to me,
And left leg
the
pain.
usually disc patients don't complain back pain. Here, everybody is talking about back pain, back pain. Usually it is happening in our practice that if patient is having a huge disc, or he is a surgical case for laminectomy or whatever discectomy, usually they don't complain of back pain. Everybody is coming leg pain, leg pain. If back pain is dominant, I don't think the case is surgical. Yes, it is, but disc patients usually complain of leg pain.
Go to the right extreme.
Right.
On the right. Side पे zoom करें अपना मार्क. Okay, the right extreme, ये कोई दिखाएंगे वो pointer दे दें.
पॉइंटर सर के पास सर को दिया था मैंने, पता नहीं किसे पकड़ाया होगा पॉइंटर, सर को दिया था पॉइंटर मैंने, उसके पास है वो सर को
Look at this X-ray, this MR picture. Look at this MR picture here, and look at the lateral views as well, the coronal or the sagittal ones. And look again, once again, as I said to you, these are the fat that you see on the lateral exits. At L4-5, you see a little compressed. Here it is more as you go more far lateral. Inko upar karen ji. Here. So I think this is an area which is little in doubt, but these are not the far lateral. This is the one which you see on the far lateral with the exiting node. Now go to the axial one, please. This one, please. This and this. Zoom. Zoom further. और zoom कीजिएगा. Okay. Now the other trick that I usually do is, which I learned from Turkey, Mehmet Zalili. You know, he's a very, very famous and he's been coming here. Mehmet is a good friend and very good spine. He's a big name in spine surgery. You use your mobile, take a picture and zoom it. And then you'll be, because the MR over-diagnosed. It over-diagnoses things. Some gentleman just said that, you know, the central disc is put pressure on the ligamentum flavum. Ligamentum flavum is not like, you know, tissue paper. It is a ligament. Don't get carried away by MR pictures. See what the patient is complaining to you. It's a back pain, 4 years, fine, you have been treating, or many people have been treating. But now for the last 1.5 months, the man has got a radicular pain. And this is his MR. I don't know what was the MR in the previous years, but this is the MR. And now there is a case to go for intervention. What type of intervention, as I again said to you, depends upon, you know, how you feel comfortable. And what is the choice of the patient that he wants some specialized type. Other than that, standard, sort of interlaminar, either microscopic, because now it's all very, very, limited here, because you've got very good drills. With very smart drills, you don't have to remove the bone. And you can just go and take out the disc from there. So I think this would be a case where I would think that I would consider him a case for surgery.
And these are the X-rays of the same patient. Any questions anybody wants to ask? Or otherwise we would conclude the session and you guys can proceed.
This is the same patient?
Yes, sir. This is the same patient.
Are there flexion extension views as well?
Yeah, these are the flexion extension views actually.
Okay. One more point that I would like to make here is that if it's an elderly patient, another thing which we will not find in the book, there's so many things which I'll tell you is you will not find in the book, but you will be saved from something which could be embarrassing. Because the patient who have removed a disc, he's come back to you after 3 months or 6 months, say, doctor, I've got a pain. Why I've got a pain? Because he has an unstable spine. You did not fix it. You just removed the disc. It's a 4 years history. So he was having a mechanical pain for 4 years, and then he developed a degenerative because the annulus ruptured. So I think that is another thing that you need to see. So now I'm more and more into people, anybody above 45, I'll go for flexion extension views to see, is it an unstable spine? But at the same time, having said that, I would also like to tell you that there is an unnecessary, there's a gentleman who comes in the same place where I work, and he says, sir, your results are much better than mine because I put so much metal. And I think it's unnecessary to put so much metal. But I said, no, there is an indication for that if the patient has an unstable spine. Yes. So I think just, a word of caution that for somebody who keeps coming a long-standing back pain and then a recent disc, then you must do flexion. It just takes, 10 minutes. It's very inexpensive, but I think you must do. And here you don't see any listhesis. You see a lot of things that you see on plain X-rays. Intervertebral foramina. Here, look at the size, and look at here. You see a lot of things. And then all the posterior elements are in line. On flexion extension, there is no movement there. I think very easily you can go and you will be very safe surgeon, because tomorrow, if you have to address the audience, you can say, no, the patient did not have a problem, unless something else has developed, like that gentleman who had, leukemic pains, and there were bone pains and metastatic pains. The other thing is, AP views. What are these things? It's okay. What is this? Name?
Sorry.
What are these? These are pedicles. If they are eroded, there are only two diseases, or rather, there's only one disease where it is eroded. It is metastatic. It is malignant. Even in TB, the disease is intervertebral. The disease of TB is here. The end plates get eroded. Patients come to you with back pain or leg pain or fever or blah, 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 that you need to look at. A plain X-ray is my guideline to have a basis for what is the underlying cause. Because TB is so common in our country, in early stage, you can be misguided or you can be misled. So you must see a plain X-ray. I always look for a plain X-ray.
I want to add to Sarnaim that as you told that backache is not a problem, but if in this case we see he had 4 years backache and then starting relating to the leg. So what I observed is that these patients initially present with backache, most of the and when the patient the annulus rupture in the disc come out and it compresses their nerve root, most of the time the back pain is gone. And second thing I want to add that we always do the flexion extension exercise with those patients with the claudication who have stenosis on MRI. So we have found that 5 to 6% patient have this disease and they need fixation. Thank you.
Are there any more questions or comments, or should we proceed for, you have
Question. One more question. Contrary to this case, there is disc herniation in this case, the level of L4-5. I have come across patient with radicular pain, but no disc herniation, or very small or insignificant herniation of disc. So what about these patient with severe radicular pain in L5 or in S1, and the MR is either normal or is very insignificant disc herniation?
I think that is something which I have been talking time and again, that please be careful. Very careful when you look at the MR, because if MR doesn't show that there is significant herniation, what are you operating for? Because the signs and the symptoms, but the pathology is not there. And when you'll go in there, you'll find the disc is quite hard. It is not ruptured. Because once you have done almost 100 discs, you'll find that the moment you look at, you retract the nerve root, you'll find that, the disc is very hard, and it'll be not very fair to disturb the normal anatomy of the disc. So my humble suggestion to you and the request to you is, please be careful. If there isn't any, significant herniation, either central or lateral or far lateral, please don't operate. They settle down.
Sir,
Believe
if the
me,
patient
they
is-
settle down or look for it. Are you under stress? Is there any problem? Is your, sort of postural problem? Things like that. So please, if the patient does not have a significant disc, unless the MR you do a special MR to see far lateral disc. In 1 or 2 patients where there wasn't any significant, compression on an ordinary MR, I looked at the, the far lateral disc. So the far lateral disc can give you. Okay, I think we have to stop here. So far lateral disc could be one indication when you don't see a very significant central disc or a lateral disc. So far lateral disc, or maybe, exit foraminals are there. So I just do a foraminotomy in these patients. That's of course a little different to go into that topic of, when to operate, when the patients still keep on coming again and again with a, a complaint of leg pain, and the MR doesn't show a significant disc. Yes, there is something that you can again discuss in a group, and then you go ahead with that.
Thanks,
So
sir.
I think we just conclude. We can continue the discussion later on, or discussion over the tea break. Go and grab your cups of tea in like quick 5 minutes and then be back. All right. Thank you.
Just one. Before you leave, just one more thing is the gross anatomy, the surface anatomy is very important. In few cases I've seen that people have been operated on the wrong level of the disc. So you must master, and I think, Naeem knows it, my, surface anatomy indicators are the iliac crest. And 99% you will be correct if you know how to place your incision there. So you may be operating on a wrong disc. Like I could be operating on a wrong disc. Thank you.
Hello?
Yes, we can see you. We hear you.
Okay.
Yes.
Okay, so where we are now.
I think we would request you guys to just stay back because they're just starting with the case. So we're here.
Okay, so. So that quick now, the patient is at start, the patient is in front position, fixed on the table, fixed on the table. We have prepared the CR. The CR will go lateral constantly all the time. That's what we are doing. We have put bolsters under the patient. The tummy is free. We have bent a little bit the table. So like that, we open the foramen a bit, so we create a bit more space. Although this is a young person, the foramen is really good, so we should have no problem with getting there.
Sure.
This is what's happening at the minute. So the next step will be the next step will be we are going to do X-rays. We have to make sure that we have true AP and true lateral in that surgery. This is the surgery where the true AP and true lateral is probably the most important. We need an X-ray, right? And all right. Can you give me if you have sorry?
I think the top camera is better. Sure. Yes, yes.
Okay. So
Okay.
the next step.
Yeah.
We're gonna do AP and lateral X-ray just to see how good are the pictures.
Can you show us the MRI also?
Okay, so MRI scan, can we show the MRI scan? Yeah.
Acha. Acha, acha.
So today we are going at level L4, L5. L4, L5, transforaminal approach. We have a disc herniation, which is at L4, L5.
Yes.
It is on the left-hand side. That's why we approach the left side.
It is the same.
Okay, so you can see that this herniation might be here at that side. Sorry. Yeah, so we can see that this herniation
Yes.
and you have L4L5 level, left side, this herniation located roughly at the level of the disc. So it is so young man, L4L5, good for a favorable case. So I would say relatively easy to do case. Agree, Farooq?
Yes, I'm agreeing. If you look at the X-ray, the most important thing is to see the X-ray preoperatively to see the height of the foramina, especially this. If you look at this, so this is the foramina. What is good enough to introduce our needle, and initially we will hit the SAC, and then we will introduce our needle into the foramina, and then we will remove the disc. So preoperatively, X-ray is very important to see the height of the iliac crest. It should not be above the foraminal level, especially for 4-5 level, because some patients have a high iliac crest. So a lateral X-ray, if the iliac crest is little below the foramina, so your X-ray can be easily done, and also see the height of the foramina, and also see if there is any spur. Sometimes in old patient there may be a spur, so you have to remove the spur through a blur. But this is a young patient, foramina is quite enough, the iliac crest is below, and we will do a transforaminal approach. If you look at the MRI, so here is a disc herniation, which is just touching the facet triangle. But if you go from the lateral side, so we have to make our entry point lateral is possible, because the disc is just medial to the facet triangle. So we have a lateral approach. So if anyone have any question, can ask from Dr. Nirmal.
Yeah, so I agree with Farooq. Usually L4L5 is accessible with this approach for most of the patients, but sometimes, especially with men, you may have quite high riding iliac crest that will obstruct even L4L5, so you have to check that. And yeah, so we have to go a bit more laterally. We have to go low here.
Okay, and now you have to put the camera on the patient.
We have to start planning now on the patient. Okay. So do you have radio tape instrument to start planning? And
so this is the basic setup. Patient pathology is on the left side, so we will stand on the left side. The scrub nurse will be on the left side, while the CM on the opposite side, and the monitor are on the opposite side. So for the patient position, the first thing is that you see on the naked eye that the lumbar area is placed. So how we place it, because sometimes patient having a hyperlordosis. So we break the table to reduce the lordosis and to open up the foramina. And you will we will go from the left side. So the scrub nose on the left side. Here we have irrigation on the top. So continuous irrigation throughout the surgery. And here is our RF. We need the RF ablator, and this is RF ablator we need it, because with this RF we have to coagulate the thing. We have to stop the bleeding, because if there is a profuse bleeding or any tiny bleeding, so it will disrupt your visualization. So we need this, and all the instruments you have seen on the top. So this is basically the position of the patient. The CM is now. Initially, we will do an AP image to see our desired level, and then the lateral level. And also, there will be there will be only a single disc space. Here we are going to work more parallax at that area.
Yeah, so the other thing that I wanted to comment, so excellent comments. I wanted to comment also to ask about the irrigation system. Do we have
gravity irrigation system or we have irrigation pump? Yeah, we have only the gravity irrigation system. For the gravity irrigation system, it should be about 40 to 60 centimeter above the level of the patient. So you may have a safe if you know intraspinal canal irrigation 40 to 60 centimeter above 45 years. That's very important. I have a patient that developed a water pressure injury. The patient had here for a period of time. The patient recovered, but this is very important. I don't use irrigation system, which is gravity. I use a irrigation pump, which automatically will shut down if the pressure goes above 50. But what Farouk said is equally well. So if you put the, you can regulate the pressure with the height. So that will be the hydrostatic pressure that we need. And also the most important thing, when you start your irrigation, just look at the outflow. If there is a free outflow, so it means that your irrigation canal is the inflow and outflow is equal. So there may be you are safe. So if there is no outflow or the outflow is not enough, as you can see from the inflow, so you can again decrease the height of the irrigation. Correct. So a lot of things to okay. Okay, so do we have marker? Okay. So we need some metal instrument, please.
Please put on roof camera.
So first thing is
Roof camera, please. We are not able to see. This is okay.
okay. Initial initial image just put up okay. So the next step will be a planning of the entry point. In that surgery, the entry point planning is very important because once you do the entry point, you cannot change so much the trajectory. There is a degree of you can change the trajectory with a few degrees, but not so much. You know, the skin is very good planning. There is different systems. Some people are calculating sinus, cosinus, angles, centimeters. For me, this is a bit too much. I like not to do that, and I've seen that Farouk does the same way. He uses a few lines. We're going to show you now what lines we are using in order to avoid remembering centimeters, in order to avoid calculating, very, very much. So the way how I was taught initially, when I was going to the courses, you have to learn specific centimeters. You have to learn that, let's say, at L5S1 is this many centimeters, then at L405 is this many centimeters, and then at 3-4 is this many centimeters. But how I was not possible to understand how somebody who is 60 kilos and somebody who is 120 kilos is the same centimeters. So that's why I tend not to remember centimeters. It's about remembering points and the landmarks. So again, I will add something. The fixed measurement is not always correct because of height of the patient and weight of the patient. But some countries use this because for transforaminal, which we have two types of surgery. One is inside out and the other is outside in technique. So the countries use the fixed diameter from the midline, that is 12 to 14 centimeter, or 5 is 1 and a 4 5. So initially set off on the essay. Then they do a foraminal path. And then after doing the foraminal path, they enter the rest. But what we will do, we will do inside out treatment. Yeah, so we're gonna mark the midline. We're gonna mark the midline roughly. And then we're gonna go further. Let's put the marker and see if the midline is here. So the other thing is you roughly can get yourself oriented where will be your disc. So you do a left X-ray. So let's put up and see. So yeah, so there is that what for commended. It depends also on the system. So there is systems which you can use for abdominoplasty. You have reamers which can help you to open the okay. So we are roughly there. We are roughly there. So this is our midline. This is our midline, and so then the next thing that we have to do is we have to what? Can we use so maybe something to try or maybe the needle. No, give me that long needle. Give me that long needle. Do you have enough long needles? So we can use the long needle to use that because this to easy procedure.
हाँ जी बिल्कुल मतलब आप
So as you look at so the next thing is so first is midline, second thing is the disc line. Yes, image. And now this is the first line for a transforaminal surgery. This is a line 1 or line A or it is a spinous process line. So you all can see that this is a spinous process line. And this is line A. The second is we will draw a distal line. It is at the level of the disc. Image. Image. The most important thing, here you are going for a transforaminal. The inset should be parallel, correct? So I was going to say that. If you look at this, okay, just tilt the arm toward inferior number one. So give a little bit of a lower dose. That's what he wants to tell you. So you have to incline a little bit like that way. Yes. Open there, yeah. Then just push that. Yes, that's it. Okay. Okay. Image. Okay. Image. Oh. This is a discal line. So we draw a second line, a line B or a discal line, which is from the center of the disc to the lateral side. So again, I will confirm because either it is 4-5 because the patient have a this is yes 4 yes 3-4 because the patient have a large interlaminar foramina below. But if I look at the spinous process of the 5, so it is fused with the sacrum. So I will again take a localization. Okay. You can see on that X-ray that the iliac crest is just touching, is just tangential to our line. So we should be okay with that. Also, when you're entering the disc, you enter the disc slightly under angle as well. So that should be okay. The iliac crest should not be on our way. Okay. Now we will do a lateral image. Go down a bit, please, with the X-ray. Machine, the base, yeah. Down south. So, okay, this is south, this is north, this is up, this is down, okay? South, north. And again. 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 So this is this inclination line.
Is it third line or it is the just lateral view of second view?
Yes, this is the third line.
Okay.
Already we drawn the two lines. One is midline, the other is discal line, and this is this inclination line.
Yes.
So this is this inclination line from the interior of the vertebral body to the posterior surface. And it should be, and we measure it. Yes. So the other lines, yeah, okay. Before I was gonna say, I take two more lines, but keep taking them as well. So this is, now he's taking the he will take the supraspinous line and also the posterior vertebral line. Yeah.
Excuse me, why this third line is oblique? It is entering from the lower vertebral and it's going up. Is it it should be like this, or it can be even from the middle?
This is the called the disc inclination line. That's why it's
All right. All right.
So this is posterior facial line. Yes, and it is very important because whenever you are doing a transforaminal approach, so your entry point should be.
Can you show it on the higher, can you show it in large camera?
So we are on the side of the patient that is not.
Yes. Yes.
We have taken the posterior, the posterior facetal line, the suprafacetal line. So the suprafacetal line is important because if you put your entry point below that suprafacetal line, it is likely that you will go through abdominal organ and you will have abdominal organ injury. So that's why it's very important. You never go below that line. That's the importance of this line.
Where is superior facial line? Which line is? Please, can you mark here?
So you can see the instrument.
This, yes. Yes.
So if you see the X-ray, you see on the X-ray we have put that instrument above the facets.
All right.
So that's what is it. This is the posterior facetal line.
Yes.
So you don't go below the facets, or where is the projection of the facet on the skin.
ये लाइन है सर, ये लंबे
Now I have to look at the API correct. Like an image. Yes. Again. Okay, any question up to now?
Why you are looking the iliac crest line?
Because we will introduce from the lateral side.
All right.
We are just near to the iliac crest. So if we passing the dilator, it will be difficult.
All right.
Cross the dilator just near to the bone. So we have a bit away from the bone for a safer entry.
Okay.
So I take another line as well, which is the supraspinous line. You can take it, you cannot take it. So we are okay. We have a lot of lines here, but usually I will take the supraspinous line, which will be somewhere above the suprafacetal line, and that will basically designate the place where you are not going above that. If you go above that, you're not gonna have good entry trajectory. So
All right.
it is, you can take it, you cannot take it, that's fine. But,
No, we should take it, but can we see on the
up a
X-ray?
little bit, up in the air. So you have to go a little bit north and go north. Yeah, yeah.
No, it's still not visible.
So that.
Not visible.
So you
Yes.
can see now that this my instrument is right above the spinous process. Can you see there on X-ray?
Yes, yes.
Right above the spinous process. So
Yes, sir.
you can see it's intersecting. So our entry point will be somewhere in between these two lines, and usually it's good enough for me. But for measured it, so how much did you measure?
13 centimeter.
So we should be roughly somewhere here. I normally, what incision do you do? I normally do slight, like horizontal incision, so like that gives me a few more millimeters too.
Yes, these two lines are very important, especially on the left X-ray, because if you are doing a transforaminal approach for L5S1 or 5, so your end point should be posterior to the facetal line. But if you are doing transforaminal surgery for L1, 2, or 2, 3, or 3, 4, so your entry should be posterior to the spinous process line. Because at upper lumbar level, we have a kidney, we have a retroperitoneal area. Yeah. So that's why it's very important. Correct. Say very simple. Okay, let's start. Okay, cleaning. Will they clean for us or okay? So let's go and scrub. Okay.
नहीं सर ये नहीं सर सर ये सुपराफिशियल लाइन है, ये स्पाइनल लाइन है, ये डिस्कल लाइन है, ये दोनों, और ये वो इंक्लाइन लाइन है, वो उसकी लाइन है, उसकी नहीं इंक्लाइन सर, ये जो ये लाइन है, ये उसकी लाइन है इलियक क्रेस्ट की, ये सर ये इंट्राडिस्कल लाइन है, ये डिस्कल लाइन, ये दोनों, ये वाली इलियक क्रेस्ट की लाइन है, वो L4-5 की, ये L4-5 की, ये L3-4 की, इंट्राडिस्कल लाइन है सर वो।
So you practice in the shower? Yes.
Excuse me, can you again summarize the lines once again from 1, 2, 3, 4? Number 1, it is interspinal line, and number 2, it is in intradiscal line. Can you summarize the lines again, please? Yes. Yeah. Is it superior egress line? नहीं सर, ये L3-4 की है, ये L4-5 की है, ये इलियक क्रेस्ट की लाइन है, ये सुपाइनस प्रोसेस की पोस्टीरियर, और ये सुपीरियर फेसेट, हाँ, और ये स्पाइनस प्रोसेस लाइन। अच्छा हो रहा है। तो वहाँ पे वो भी नहीं लेटा होता, ये नहीं रखते होते मुझे गाँव में पेशेंट फ्लैटेबल में रहता है लोकल में, बस वो ऐसे ही थोड़ा होता है, बस वो फ्लैटेबल। एक पॉइंट मिस होने से आपका सारा काम खत्म हो जाता है ना थोड़ा मेरे ये कोर्स कराया था तो थोड़ा केसर ब्लॉक रिजेक्शन इसका पूरा मिल रिजेक्शन अब हमारा एक पॉइंट कहीं मिस है वो नहीं जाता उसका निकल नहीं जाती वही देख रहा है कौन सा पॉइंट मिस है हम वो लगा देते हैं इसका ये जो है कॉक्सी टाइम का ये जो एपिड्यूरल है ये बड़े आराम से लग जाता है लेकिन उसका फोरामिनल का एक पॉइंट कहीं से मिस है में हेड होते हैं वो नहीं आप करें जाते हैं कोई ना कोई पॉइंट फिर मिस होता है व्यक्तिगत में बड़ा फर्क आपने आपने एक बात जाने एनोरिज्म में ये मैंने वैसे अब हमारे with 15 less than 15 फिर आपने क्या था एक पॉइंट था आपने कहा था रोकेट बाइफर्केशन का है सबसे जल्दी था वाकई वो जरा सा आप उसको चेक करें एक पॉइंट था एमसीए में टेम्पोरल लोब पे नहीं लगाना आप लगाए तो वो फट जाता है यानी ये छोटे छोटे पॉइंट है प्रैक्टिस जो आप करेंगे तो पता चलेगा करते हैं ये गाँव में लोग चीजें हमने फ्रंटल देखता हूँ फ्रंटल पे और जैसे पिछले वाला की ऊपर
for infection purposes, one per patient is good. I understand the cost as well. If that is something that will save, yeah, if that will save, if that is something that will save money to the patients, if it's safe enough, I might consider it. As you know, I'm not born in UK and I haven't worked in UK all the time. I was working in Bulgaria, and in Bulgaria, the economical situation when I was working there was not great, and we had to consider similar things. And also the patients, the situation in Bulgaria is that the patients are buying the implants. So it is, I understand where you're coming from. Ideally, it is good to use single use instruments, but
excuse me, can you summarize the lines once again?
I say that ideally
hello, can you hear me? Yes.
lines, okay.
Yes, summarize the lines. Yes.
We have central line, which is the midline.
All right.
We have then the disc line. Then we have the disc inclination.
Whoa, why these are two lines or disc lines are two here?
So like that so like that you meet the two lines and you can measure to see how much laterally you go.
No, excuse me. The disc, how many disc lines are here?
So you have horizontal line and you have disc inclination line. So you meet the two lines and you can measure how far you have to go.
Disc line.
Another way to do that is you measure and you take the suprafacetal line and the posterior, the supraspinous line. So suprafacetal and the supraspinous line. And your area of interest is normally between these two lines at level L5, S1, L4, L5, and maybe L3, 4. If you go on the higher levels, you have to go above the supraspinous line because of the kidney and other organs. So basically, otherwise you're going to go inside the abdominal cavity. You don't want to do that. Is that clear now?
Almost.
Almost. Okay.
वो आप सही कह रहे हैं इसका लाइन जो oblique है वो जो oblique जिसकी जाती है एक वर्टिकल कहीं ऊपर हाँ जी वो लाइन वो ये वो नहीं है ये दोनों है ये वाली लाइनों है दरमियान से गुजारी थी इसका लाइन एक जो है वो जो oblique लाइन
बड़ा और एक छोटा वो है ब्रेक है छोटा सा कपड़े वाला हाँ नहीं वो पानी okay Urdu okay the first thing when you are going to do a transforaminal approach the first line is central line. It is called spinous process line. So you see, this is the central line. The second line is a discal line. You draw a line from the center of the disc to the lateral side. And this is called line B or discal line. So this is the second one. The third one is the disc inclination line. Why the disc inclination line is important? Because of two reasons. One is you have to calculate the entry point from the midline. And the second is you have to correct the lordosis of the 4, 5, and 5S1. So here these two lines connect with each other. So this is basically the disc inclination and the discal line. So this is the entry point. The third one is on the lateral X-ray. We do a two line, which is very important. One is posterior facetal line. You don't do your entry point interior to that. And spinous process line, because at the upper lumbar level, if you do your entry anterior to this line, so you will damage the retroperitoneal artery. So in the beginning of your practice, your transforaminal will be mainly L3, L5, occasionally L3, L4. You would not go L5S1 for transforaminal if you're a beginner. And the upper levels discs are very rare, and you would do them again with the traditional technique that you know. So if you want to do L4, L5, which will be the level that is most important and most common for you, you will do L4, L5 transforaminal. You need the central line. You need the disc. And then discal line, then you intersect with the supraspinous line, and you intersect with the posterior, the suprafacetal line, and then your object of interest, i.e., the entry point, will be between these two lines and on the discal line. So this is as easy to remember. You can do it that way. So if you want to go more medial, if your disc is more medial, you want to be closer to the suprafacetal line. If your disc is more lateral, you're going to go closer to the supraspinous line. That's to recap. That's to summarize. Is that a bit more clear now?
Yes.
Okay.
Thank you.
So the other thing is, how do we go AP and lateral with this? We will put sterilized down or sterilized wraps towel. But when you go AP lateral, then they get contaminated.
Yes.
We have a lot. Can I have? Do you have just towels? Yeah, we can do this. I have something that's PCR or drape. But if you give me 2 towels, I can simulate it here. Okay, so if you give me 2 lines, two sheets. So give me that. So that's 2. Do you have a smaller one? That's okay. We can do that. Okay. Yeah, all right. So just stay like that. Get it from here. Do whatever I do. So the other way around. Yeah, just like that. Yeah. So just you have to make a fold. So this is basically something that we can do like a C-armor wave. So we remove that, and then we stick that here like that, just like that. We stick that here like that. And now I need 2 articulates. So this gets like that, and it stays like that when you're AP. When you go lateral, you unclip there, and then the X-ray comes here.
It
And you will lift that pole, and so that will be covered. So this is sterility. No, I have this. I have it done. You know, some company did it for me. It's called C-armor.
तो सीआर में जब ये आपका नीचे से घूम के ऊपर जाएगा वो इन्फेक्टेड कर लेगा ना नीचे से आके
Yeah. Okay. Yeah. Okay. Yeah, sure. Yeah. Oh no, I have to leave. Okay. Skin cut. Okay, let's do a skin cut. Let's do. So give me a skin cut while you're preparing. We can entertain ourselves and we can start the skin cut. We can start the needle. Let's speed up some time. So the next step of the surgery will be we do the skin cut. I do a small horizontal skin cut, and then I introduce that needle, the spinal needle. Then through that spinal needle, I will drop that spinal needle on the superior articulating process of the L5, superior articulating process of F5. Sorry? Oh, that's good. Thank you. Okay. Skin cut. So that's what he's doing now. He's preparing it's important for you to prepare the instruments, the scope. He's focusing the scope and he's doing the white balance. So you have to use some text to focus the scope nicely. To orient the scope is also very important because if your scope is not oriented, you're going to get yourself lost and you're not going to know which is medial, which is lateral. This is very important. Always know where is up and down. And what is the orientation of the scope? Knife? Okay. So started. So normally here when you go, I do a small incision and I try to penetrate also the fascia. Otherwise, it's very difficult for the instrument to go, the dilator. Okay. Right.
Can you remove this gauze? Can you remove the gauze away? Yes.
Yeah, we just did a small skin incision. That's what we did. And now we're gonna introduce the needle. So the needle, basically, all these lines that we did, they are for that needle. So the trajectory of that needle should follow the trajectory of this line. So basically, my trajectory, that needle will be pointed towards the intersection of the line, the discal line and the midline. So I'll be pointed that direction, okay? And then I introduce the needle, and then I have stopped on a bone now. So now the next thing is I would like to see X-ray just to see where I am at the minute. So that trajectory, what you can do is if you want to practice that trajectory, you can do injections. So the tradition, in one of my presentations, I was going to show you. I'm going to show you what I'm doing. I'm doing a presentation on injections. So the traditional way to do the transforaminal injection is to go for 5 centimeters offset. Lately, what I started doing is I started doing this long offset with a long needle when I do my transforaminals. And like that, I have two advantages. Number one, I'm training that trajectory. Number two, I am having 100% penetration of the foramen. Even if the foramen is very narrow, if somebody is very old, with that, I can penetrate the foramen, and I'm sure that I have done proper transforaminal injection. So if you would like to start doing the transforaminal, I advise you start doing injections that way. So it's safe for the patient, it's beneficial for the patient, it's beneficial for you. So it's a good thing. X-rays. So I think one should be connecting, the other one should be doing, because it is difficult to.
How long needle do you need for this transforaminal injection by this approach? It is more than 15 centimeter, 20, or what should be the size?
So what is that needle? I don't know. I know that.
No, what should be the size?
But is it range what 8? Yes, 18 get needle, and length that is around about 233 mm. So it is the 18 gauge can be used and 0.8 mm of for the key wire, for the wire, yeah, and that is the key wire 0.8 mm. Usually this will come with the set, the set that you so you have to, in order to do that surgery, you have to do you will have a special set. So what you can see here, I am probably about now. So you can see on AP. Oh no, it's not that's okay. Yeah, so you can see that I have stopped on a bone there. You can see
actually the person is in front of us.
So on the left-hand side of the X-ray, you can see that the tip of the needle is just against the bone, and I feel a bone here. I cannot advance it more. I feel a bone, so I should be roughly somewhere where I should be. But now the next thing is lateral. Yes, so we're opening this now. So just stop. Okay. Yeah. Okay. So. Okay. Go. So if we drop it, it's gonna probably. So you can click it here. You can click it. Need it. Yeah. Yes. Okay. I don't. Yes. Okay. So my needle is roughly where it should be. I have to go slightly a bit slightly down and slightly a bit up. Okay. So you can see on the left hand side, you can see that the tip of the needle is docked above the superior articulating process at L5. I want to be just on top of the superior articulating process. So you're going to see now the difference. So I have to go a bit down and a bit. So I'm playing with the bevel of the needle is helping me.
No, show that X-ray, please.
Show that?
Yes.
Okay. So now you can see that I'm exactly where I have to be. So
you corrected your trajectory.
Sorry?
So you corrected your trajectory.
Yes, I have corrected. Do you have the previous picture? Can you put the two pictures one side by side? So go back to the previous picture. That's it. So this was my first picture.
Yes.
This was my and then put the other picture on.
Forward.
So you can see now. So you can see now that this is what I have to be with my tip of the needle. So you have seen that I've done this with two X-rays roughly. Okay.
Yes.
Yeah. So see now the difference. So the left-hand side is where it should be, and then the first docking was roughly there. It's nearly there. It just needed just a little bit of a correction. So I've done it with two X-rays. This is because I found a few of these. You know, initially you'll be talking about, but if you start doing injections, that's going to help you to get that trajectory faster. Okay, so the next step is we're going to introduce.
The person is in front, please ask him to be on side. But excuse me, the person is in front of our X-rays. The one person is standing in front of between us and X-rays. Yes, okay, thank you.
Right, okay. So the next thing is we go on AP and we introduce the keyword.
नहीं वीडियो वो चौकी ठीक है काश वीडियो बना दो ठीक
Okay, so give me AP please. Okay, so we are good and we can introduce the keyword. Yes, Farouk.
I think we have to go up to the immediate particular line on the AP, and then we will confirm it on the level at the particular vertical.
So you would like
yes, you are right. We are now in the phenomena. So both are okay.
Yeah. So if I push that, if I push that, I'm gonna go inside.
Please show us the surgical side. We don't want to see the persons. Please show us the yes.
Okay. Now, so I just got it, but now if I push it a little bit, I'm gonna go inside. X-ray up now. Yes. I think
yes.
a little bit too much.
Yes.
So we have to go back a little bit.
Yes.
A little bit back. X-ray up.
Because the patient has.
Okay. So now, but we are sliding on the top, so we are back. Extremely all right. So you can see now that our instrument is just lateral to the medial pedicular line. Medial pedicular line is the line that is connecting the medial wall of the upper and lower pedicle.
And why this
say
is
either
because the
this line say either
medial to this line. So never cross this line blind. Once you put your endoscope, then you can go inside.
So that keyword is what it means. So it is not going too well. Hopefully didn't. Actually, yeah, okay, so it's fine. Right, so the next thing is you one more inch. Okay, fine. So the next thing is you go introduce your dilator. So the next thing is introducing the dilator.
So you have to rotate gently and in clockwise motion.
Actually, okay, so now going a little bit more. So somebody can stabilize for you, or if you want to stabilize. Yeah, we try, but even if the keyword gets inside a little bit, it's not a big deal. It's blunt, so it should not do a lot of problems, but still, just try it. Okay, so we are good now. So you can see that we are still lateral. Our tip is inside the foramen. We know that the tip is inside the foramen because the keyword was going inside the foramen, and the keyword was guiding the dilator. We are still lateral to the medial pedicular line. So at that point, we can remove our we can try to push it a little bit more and then extradite. Okay, and then we can remove our guide wire. That's safe to remove the guide wire. Okay. So the next thing is the hammer and Where's the? So we go with this. Good. Without long or sure that's long? No. Okay. So then the other thing is orientation of that cannula is very important. So if you imagine this is where you are going. This is the lower pedicle. Can you see my hand?
Yes.
So this is the lower pedicle. This is the superior articulating facet. So and the nerve roots comes like that. So why this is important? So this is the anatomical directions and relations. So this is the nerve root coming out like that. This is the superior articulating. This is the pedicle. So you're entering here. So you're entering here, and you're entering with your thumb to slide on the superior articulating facet. To slide and not to touch the nerve. So you're entering like that, and then you return. So if you enter like that, you can catch the nerve. So you're
please show the bevel from near.
So we are going with the
No, zoom. Yes. Now it is okay.
We are going with the pedal like that.
All right.
We are going with the pedal like that. We are going with the pedal like that, and once we are inside, then we can turn the pedal.
All right.
Okay.
Okay. Thank you.
Yes, and the main important thing is you have the table and the tip of the table and the irrigation channel. The irrigation channel should be toward the
opening of the pedal. Correct. Yes.
Because once you enter like this and you hit the pedal, then you have to rotate and gently pull inside to protect the exiting nerve root. So this will help where the table is pressing.
Yeah. There is also a marking here, but it's washed out. So it's a good practice. I do that as well. So you can mount that all the directions, but when you're mounting the tip, you have to mount it. So it's open here and it's open here, so you know where it's open. That's the point.
All right. Thank you.
Okay. Extra.
Till it is behind. Yes.
Extra. Okay.
Yes.
So we did not need so much hammering here. The foramen is widely open. We can push it a little bit just by hand. Safer than hammering. So you can see here we are just near to the superior, the medial pedicular line. We can push it a little bit more if we need to. Extra. Okay, so I think that's okay now. So now we need the lateral. So we see how far we are from the disc. Is that correct? Is that what you do?
Yes. Whenever you want to introduce anything new, either it is a dilator or a table, you have to confirm it on the lateral X-ray is on the APX, because it is too crucial. Because if once you hit the dura, to avoid the dura, as to check it on the lateral and as it is on the APMH. And if you look at the image, so we are in the foramina and just touching the annulus.
So this is the outside-in technique. If this was inside-out technique, you're gonna push your bevel more, so you're gonna enter the disc. So you enter the disc and you start removing the disc from inside, and then you go out. That's why it's inside out. We are doing outside in. Okay. So at the minutes we are good. So the next thing that what we can do is we can rotate. We can remove our dilator. We can remove our dilator. Just give me the dilator. Let me just turn it before out. I forgot to turn it. So you can turn it with the dilator. Extra. Okay. So your dilator is inside, so you are safe to turn now. You are safe to turn it. You are safe to turn. You can do it without the dilator inside, but it's safer to do it with, actually. So we can remove the dilator, but let's do another AP just to be sure that we are okay. And then we can introduce the scope. Three minutes. Well, thank you so much. I appreciate it. Okay, so probably it's a good idea to push it a little bit more inside. So give me the hammer. Give me the hammer. So then we have this special instrument that is extra. Extra. Push it a little bit more. Okay, should be optimal. So, and that's it. So now we can introduce the scope.
Lights was लेवल ऊपर आ तो लेवल है ना दूर जा रही है ऐसे पहले वो ऐसे था दूर ऐसे जा रही है अब वो इसके ऊपर आ रही है अब तो क्या ऊपर
ठीक है वाइट ब्लैक ठीक है ठीक है ठीक है the first thing is to put endoscope inside you have to see and to do a brightness before put the endoscope inside. I have to start the irrigation and I have to introduce the scope. All right.
So you can see now there is a good outflow. There is a good outflow, and initially you're gonna see something bloody there. You're gonna see it's just if you give a few more seconds, and you're gonna see that it will clear, and you're gonna see the structures. Maybe you're too inside. Just go back a little bit.
I think there is either it is working. Okay, give me a picture.
That's it. So you can see now that it's clearing up. There was a bit of a flood there, and you can see now some parts. And then at 12 o'clock up there, you can see the disc. Can you see the disc at 12 o'clock?
Yes.
So this is the disc. So we are right in front of the disc. You can see some peripheral parts. Which Tarek, Farooq will, sorry, I'm calling you Tarek. Okay, sorry, Farooq.
This is a 6 o'clock.
Yeah.
So 6 o'clock means it is the disc.
Yes.
This is the epidural case. And I have to populate the things to clear and this is to clear, this is the patient time. So 12 o'clock patient time, 6 o'clock is the desk, and 9 o'clock is the cradle, and 2 o'clock is the cranium. So I have to go inside the desk initially and will clear the structures.
But in the camera, we are looking 3 o'clock, 9 o'clock.
Yes, this is 9 o'clock. This is 2 p.m.
All right.
This is 3 o'clock. This is premium.
Oh.
And this is patient time.
All
12
right.
o'clock. And this is 6 o'clock. Actually, yes, this is there.
Whoever is inside there. So show me that top. So irrigation. So we are doing constant irrigation. If you have noticed, we have removed the plastic cap. That plastic cap can help you a lot in case there is a bleeding. Show me that cap, the plastic cap. This one. So see that plastic cap. This is something that can stay on the scope. and there is a hole that you can put instruments inside. I would use that if I have excessive bleeding inside. So I will put the cap and like that I will create higher pressure. I'll create higher pressure, and like that, the pressure will be stopping the bleeding for me.
We are not, the plastic cap is not visible to us.
Right, I'll show it again.
No, can you show on the zoom view?
So that's a plastic cap. Can you see the plastic cap?
Yes.
That's a plastic cap, and it can go on top of the scope. So the plastic cap has this hole, and that hole can pass the instruments.
All right.
So the point of that plastic cap is, if you put it and if you start working with it on, it will increase the pressure inside, and like that, it's stopping the bleeding. It's the same thing like what when you do ETVs.
It's just like that. I put my finger on the irrigation.
Yeah, and clears.
And it gets clear. So, but if you can do it for just 4 or 5 seconds, not too much.
Yeah.
Okay, give me a.
So you can
No.
see the
No, please put this picture on the larger view. On magni, yes.
Can take an image for me.
Yes. What is this?
We are going to confirm here we are. Always use the RF.
What is RF?
So the RF is the instrument that you're going to be using the most.
Radio frequency coagulation.
But you will use it as a probe. You will use it to different things. It's not only for bleeding, for stopping the bleeding. It's for dissecting. It's for everything.
The small camera does not have the light.
Yeah.
It's
Yes.
This is diathermy?
No, I think it's the camera. Maybe there is a water in the camera. Yeah. Yes. Okay.
I can give you
So what Farooq is doing now, he is cleaning the vessels and he's coagulating, and like that he's creating space as well. He's dissecting. So in the center of the field, you see the disc. So the next step is he's using that probe to get inside the disc. You can see here.
Yes.
Scissors. So there is a band. Sometimes you need to cut the band. You see that band that goes through the there is intraforaminal ligament. There is quite many intraforaminal ligaments. You're gonna see them. They have names, but just cut them. You can cut them easily, of course. That was one of the intraforaminal ligaments that we just cut.
The main thing is the fatigue of the surgeon during the surgery. Always your hand should be 90 degrees. Because if you want to work easily and avoid the fatigue, so your hand should be at 90 degrees.
This is a bit high up for you, but it's because of the X-ray.
Yes.
So now that's what he's doing is he's cleaning medially, and then you have to see the disc shortly behind that part. You can see again the ligaments crossing. You see it's from 12 to 3 o'clock. You can see another ligament. So sometimes you cut the ligament and the disc starts coming on its own. See, the disc is already starting to come. See, there is a ligament on top of that. Again. Yes. Yeah. Yeah. Yeah.
So, elimination of case, I was in the second floor of the Wonder not this much. Again. नहीं लेंस समझता नहीं है नहीं यहाँ पे नहीं छोटी सी छोटी सी
It's I keep it a little bit further down, and I also have this device. Do you have that, Baruch? This device that is keeping the distance, so you don't need to.
Yes.
Here, the factor.
Yes. Yes, I have.
Again, you can use it, but you can use your fingers. That's I think. If that's easier to use.
What is the size of channel? 8 mm?
And this is the 7 mm.
7 mm.
And working channel is 8 mm.
All right.
Sorry?
All right.
Yes, now I'm inside the so I am safe before going to see the traversing and the exiting the route. I have to I have to decompress this area, and then I will look for the traversing and the exiting the route.
You can see a 12. Nothing there. Can you see?
Not yet. No, this, yes.
Yeah, this is from the wrist. Yeah. This, yeah, looks like bulging like a distance. Can you go slightly back, Farouk? Just slightly back, okay, just so to show them.
But now you can see that I am working just on the desk. And if I slightly retract the endoscope, so you can see epidural cracks. But first, I will go inside the desk and then will go immediately to look for the
See,
fragment.
at 12 o'clock, there is extruded disc fragment there. Can you see that?
Yes.
Yes, the extruded disc fragment. Yeah, this is the.
Yes.
Now what he's doing is compressing internal.
What is the size of pituitary rhonger? What is the size of pituitary rhonger? 3 mm. All right. 3 mm.
Now I'm doing the desk.
Yes. Every time you are coming out and going in again?
Yes.
Or, all right.
And also you can see the death fragment how coming out with the
Water.
You don't see, so the technique that I can help Farouk is I can move it like that.
and this is the exiting the route.
Yeah, so you can see
Where is-
the root now just under the cannula. But while I moved 90 degrees the camera so he can see the tip of his instrument. That's what I did. I was thinking that you're gonna cut this one.
Yes.
And so, but you were not seeing it, so that's why. But I think to go inside the definition, okay? But okay, I will get this. Okay, so you start seeing now something there. Let's see what is it. Is it a disc or is it a nerve? I think so what I meant is now I will rotate to see the rotator, which one I want to rotate right now. So when you rotate the scope, you see the tip of your instrument. Yes, that is very important. So it's good to have your assistant. I think there is no. No. Again, I. Because when you're like that, when your instrument like that, you see at the bottom, you don't see the tip. If you turn it, then you start seeing the tip. What you're asking. You have to this guy. Yeah. Now yes. I am removing the disc from inside the disc. Yeah, so good decompression. So there's good fragments coming, so we can now go for the next. Yeah. Okay, so Farouk is used to do single-handedly. I can see it's possible to control the scope on his own. He's removing all the peripheral parts, so identify better the structures.
Can you show us that nerve roots which is exiting and which is traversing?
We just have a glimpse of the nerve roots.
All right.
We will expose it a little bit better, but before that we have to remove a little bit of a disc.
All right.
So what we have done so far is Farouk went inside the disc and did a little bit of internal decompression. So like that reduce the pressure, so like that create a bit more space, so it's safer to work. Because
you
you're
disgrace me.
constantly thinking that you might grab the structure that you should not grab. Yeah. And it's very difficult with the step because then you cannot press this has to go and and you have to hold and hook like this. So you can go inside and outside, and you have to use the adapter. Yes, I use the adapter. Now I am go inside the disk and to remove the disk.
What is this adapter? Is it a stand type thing or what is this? What is this adapter? Is it a stand type to hold the things or?
So basically, it's a adapter that will stay on the start of the scope. So it will create space between the scope and the end of the cannula. And then there is a screw in there, so you can screw and like that, zoom in and zoom out. And like that, the other way to do that is you constantly do that with your fingers. You have to keep the distance with the fingers. The fingers get tired, so the adapter is good.
अच्छा वो focus on zoom in zoom out करने के लिए.
Okay, so we are just now advancing towards the disc. You can see above the instrument of where Farooq is working is still inside the disc, but you can start to see now the disc is being exposed, that there is a disc fragment there. Okay, so
Now, again, you can see this is the vertebral cuts, and beneath this, I see the neural structure. These are the neural structures.
Yeah, so
this is the annulus, and this is the disc. This is the inferior end of the superior vertebra, that is L4, and this is the superior end of the L5, that is inferior vertebra. So I have to slowly go inside.
Is there legs?
Yeah.
This is 9. You're in 9 of the.
you can start seeing the nerve now at 12 o'clock. Maybe.
Yes, yes, it is visible.
Yes, this is
और चीजें साथ मिलकर
We will have that optical.
Yes.
Okay, so this is something. Okay, so now, when there is a big fragment, sometimes you need to go with a scope. So you ask your assistant to hold the scope for you, so you don't come out with the cannula as well. You got it? You got that? So if there is a big fragment, the big fragment will be too big to go through the scope working canal. So you take it out with a scope. But somebody has to stabilize the cannula, otherwise the cannula might go up and then you lose the trajectory.
Okay, so how I will decide that how much and depth I am, so I have to take an APM. Yes, X-ray. Okay. Yes, so I am just lateral to the midline, and this is paramedian, so I have to work over here.
What is the company of this endoscope? Zero.
You can see the nerve root at 11 o'clock.
Yes. Yeah, right. It is toward on the foot side. Now it is on the 12 o'clock. It now at this time it is on 12 o'clock. At this time. Right now.
Now is at 9 o'clock. Because we turn the camera so we can see the tip of the instrument that we are. The Farouk now is fighting towards the nerve, so he turned the camera so he can see the tip of the instrument. That's what he's doing. He's supporting now, he's working, I can help him, but he's used to work on his own, obviously. So he's supporting the camera, turned 90 degrees, and he's like not seeing the tip of the instrument. Otherwise, you see the back of it. And that could be dangerous for the instruments which are cutting. You can have a drawer here like that. So he has detected now, you can see he has detected this problem, which is hard. Despite this is a young man, this looks like hard. Is it hard for him? Yes, a bit hard, isn't it? Not like very precious of this. So you take it piecemeal, it's not coming on like one piece, obviously quite often. It's coming on pieces. There is, I think, these guys have one. They have also bending.
No, this is the building instrument is not from Chinese. It is from Chinese.
So there is no way. Do you have it?
Yes, I have that.
Yes. No, yeah, this, but I mean, this is just mechanical bending. I mean that you have a lever here that you can bend.
I have another one. This.
Do you want it?
Yeah, no, that the other one.
This one?
Yes.
Yeah, this is the, so I have this, but I have it on,
Yes.
But it's okay. So what is Farouk doing now? This is a bolted probe that is bending, and it goes down, you can go under. So he's just dissecting now, and he's trying to look safe that this but the disc is hard.
Yeah, the Watson chain.
It's not like a soft, that disc has been there for a while.
छोटा microfluidic type होता है ना.
You have to the first cases that you're selecting, you try to have a fresh disc and it comes like one piece. How you know that it's a fresh disc? You will see it on the MRI scan. On the MRI scan will be bright. It is bright for you. Yeah. So that's telling you that this is bit has complained for a couple of months of the, you see bright. if it doesn't resolve. If you need to take it out. But this is the first cases, they have to find a case like that. Okay, 6 months, don't 3 months. 6 months. सर अभी थोड़ा सा यहाँ पे हम ये जगह क्लियर करेंगे और ये बेसिकली हम मानेंगे देखिए just switching the upper end ये जो है ये कंफर्म हो जाएगा लेकिन I'm trying my best to remove it.
डॉक्टर फारूक ये इसका हदिया कितना है इस सारे सिस्टम का? So I am asking you road to what is the cost? What is the cost of this system? Is there any Chinese Me Too? How often a newcomer that breaks the instruments? Dr. Farooq? How often it breaks by it is broken by a newcomer?
That's given. You will have a instrument breaker. Try not to break it inside.
All right. Yes, very important.
We were talking with Farooq about that. He has broken a few instruments in the beginning. I have broken a few instruments. Everybody breaks. Usually, for most of the people that are starting to teach that, to learn that technique, the first instrument they break is not the course.
Yes.
But it's not very painful. It's painful is when you buy the instrument yourself and you break it, then it's more painful than when it's on the course.
It means cost is doubled.
These are Farouk's instruments, so we don't want to break them.
Actually,
I get them and this is the annulus. So I will get a little bit of the annulus and then I will see either the exiting and then there was nervous free. If it is free, so we done. So we have to go now and inspect around. So most of the work is done from what I can see, but we have to just go around and see if there is anything else to take from it. Although, you know, even if you leave a little bit spare, it's not a big deal. Do you burn at the end? Yes, sir. Yes. I do the same. And also it's what try to parachute and jump on the, you know,
हम देखें मैं तो मतलब हर 20 में से एक का ऊपर 20 में एक के बाद हर 20 करने के बाद एक रीड हुआ था हाँ सर और नहीं हमारे अपने की जितने भी बड़े केस नहीं आप जब आप केस कर रहे हैं ना टीम में माइक्रोस्कोपी भी उसमें भी 20 के बाद एक आता है 20 के बाद एक आता है हर 20 में से एक आलू आपके तैयार हर माह एक आलू आपके सामने बढ़ा डिस्काइटिस हो गया डिस्काइटिस ना भी हो जनरलाइज बैक में और लाती कर जा रही है मर गए एक सवारी मौजूद है हर महीने
There is actually a paper that is supporting the burning, and it's coming from who? Here, two benefits of burning inside. One is that you have to burn the chocolate, the loose fragment, and the other thing is if you stitch it on the annular tear, you have to sign what is on nerve, so the patient have a list. The paper I'm talking is that there is a good paper from Wu and Kim, and they found many cases. I'm not sure how many, but what the. Now, this is the epidural space, anterior epidural space, posterior to the disc. This is the annulus. Why I'm not putting the annulus up to the midline? Because I don't see any range in this. If there is any range, I have to go and put this annulus. But the main culprit was here, and still here is a small herniation with here. I will completely remove this, and again for anatomical purpose, I rotate at the superior. So this is basically the axilla. Beneath the tip of the working sheet as the exiting nerve root. This is the axilla, and this is the traversing nerve root. So if that was a good very good view, you can see at 3 o'clock at the minute the exiting nerve roots, and then at 12 you can see the traversing nerve root. If you zoom out a little, just zoom out. Yeah. Okay. That's it. Okay. Good.
Can you show it with the pointer? All the landmarks.
Yeah. So I suggest, just in a second, we will be done, and then we will do a walk around and we'll show you the structure.
Okay.
But the most important thing is you hold your instrument and you hold the endoscope. Because if once you lose your position, then it's very difficult to relook at. You have to start from scratch quite often. With the needle. Yes. Follow. You have when you sometimes I was supposed to this with the dilator. So you still feel less resistance there. so it's not. Maybe I was exaggerating when I said that you have to go with the middle, you should go with the dilation. No, you nothing. Yes, nothing. Okay. I'm just at the level of the medial pedicular bone. I will not go in. I will hold it because of this is paracentric. So I will hold the scope and the working sheet at the mid pedicular line. Yes, indeed. That's why I take this image. I don't want to cross the midline because the pathology is on this side. Please. Okay, this is basic. No, this is yes. This is basically 4 mm. The biggest one, I think, the rounded, and the tip is this is 4 mm. So you can dip it and slide the way 6 to 7 mm. Don't do more inside. So a good trick when you're inside the disc is when you turn it, you still feel the bone. You stay. If you're asking if you can go beyond and hit the yes. So good trick is when you turn it, if you still feel you can turn and open, and if you feel bone, you're inside. That's also good trick even when you do Okay. Most of the work is here done. But for a beginner, that should be short test, short duration. That's what I said in my presentation. For a beginner, it's 10 months of duration. So this is the lower end bit. This is the upper. The upper end, this is the lower end bed of the upper vertebra, and this is an upper end bed. So now this is not good. Again, I slightly go inside to see either there is any fragment or inward here. If no, then we can wind then complete our this. These are still small fragments there, but leaving patient mind. Who's that?
Is there an instrument like CUSA or nucleotome which can make it which can divide it into small pieces? Dr. Farooq? Yes. Is there any instrument like CUSA or nucleotome which can divide the disc into very, very small pieces?
No.
Not yet.
Because you can do higher temperature.
All right. All right.
There is some company have to produce divider.
Divider. All right.
And also for the transforaminal or endoscopic discectomy, you need all the instruments, all the gadgets you need, because sometimes it's difficult that you remove others, you have a curve one, a tactile one, the big, small, upward. So I am burning inside the list. And here again, I notified myself. Give me the third one.
That's the body you that's the beginning. Now the genuine directly arm the only there like ले रही लगी उससे ज्यादा तो नहीं है जितनी रूटीन में 11 एक्टिविटी देख लगती है उतनी लगती है वो आप देखा पढ़ाने में और सारा करने में अदरवाइज उतनी लगी हाँ नहीं शुरू में देखे वो तो लाइन ड्रॉ करने में मुझको इतना नहीं है लेकिन वो है एक स्टेप मिस हो जाए ना आपसे फिर एक स्टेप आप एक लाइन मिस हो जाए ना कैरी लाइन ये पाले की तरह है जिससे कंपनी 100% नंबर अगर आपका एक भी गलत मिला तो तारा नहीं चलेगा 5 लाइनें और सारी परफेक्ट होंगी आधा होगा आधा
Going on. I don't think they are. I stopped it, although he says he still did walk. I like to be under general anesthesia. They don't move. Otherwise, sometimes they move, and once they move, I will lose the X-rays. And so that's the dural nerve.
This is opposite, and this is anterior to the dura. Yeah. And if we look at
the extended nerve would there up to as well. This is where the thing is going to go to.
Now this is the anterior vertical section. Yeah. And this is the distal. Here the herniation was. This is the epidural bed. And I rotate my canula. So this is the axilla and the exiting nerve root. And if I look inside the disc, so this is the disc area. I think. Now, that is it. Yes. All right.
Yeah, that's cool. Take a chance of that. Good. Hold on. Oh, I'm probably thinking,
Now, this I get, enough. I think that's enough. I think it's clear. Yeah. But here, something is in the tip of the flower. We want, but no, yes. This is just, and this is the, yes, okay, now.
Yeah.
For this. Yeah.
Quite big piece.
My last 5 minutes, last 5 minutes.
Check who may want to keep browsing and something. Put this type of word. Very type of thing. देखो बता बता मारते रहते हैं तभी जिसमें उसको स्कूल में हो रहा था लेकिन उसमें वो रिक्वेस्ट होता है उसमें रहा था वो भी मैं बात कहीं ना कहीं पढ़ा करते तो यूजुअली आसन में काम करता है
Yeah.
मेन कल्प्रिट
Does that come from the district part? Yes. This is just representing that, this one. So the superficial part, yes. Ah. And again.
रूह का जो फूल है एक डिफेंस में है और एक फोकस है ये वही तो फरूक है तो हमें उन्हीं को सामने दो मेडिकल कॉलेज हैं तीन ब्रांचें हैं तो एक डिफेंस की है और एक इलाहाबाद
Because you're we are not sweating.
ये तो मतलब ऐसा वही अच्छा बंदा पैसा वाला है पैसा वाला है मेरी वाली सफिया ना वो सही बात है पैसा बात
Now,
वही तो
any question? This is the anything, anything.
69 उसमें एमवीटी ह्यूमन अब कुछ
Should have paid it.
40 cases, also private one. There is more than 100 cases.
Any question from the audience? Yes, we have a exiting nerve root, we have a traversing nerve root, and here is the disc, and we remove the disc. I can't find any annular fluid, so I don't go medial as possible, and I just remove a paracental disc herniation.
Little bit focus problem.
Advantage of the spine surgery because you have to populate things away, and also you have to drill away from the lens. If it is too much near, so the lens can damage. You can damage the lens. Also, yeah. So I'm in front of the dura now here. Can I have that through?
The rupture piece or root here under the
अरे वो सारी आंखों पर रियल में हो जाता है और मैं माइक्रोस्कोप आपके पास होती लगा की या
हमारे पास उधर तो इसकी है जायज
वो बड़े वाली दो
पहले लाइट आती भी जायज
ये वो निकाल रहे हैं अब ऐसा भी लग रही है ना लेकिन वो भी नहीं
मुझे नहीं करना पहले इंजेक्शन लगाए जब आप हो गए प्रैक्टिस पूरे केस
इस अप्रोच की प्रैक्टिस के लिए करेंगे
अली बाबा में चाइनीज कॉफी मौजूद उसमें सेलेक्ट नंबर लोकल वेंडर को देना एयरपोर्ट में वो कॉपी बना देना 20-25 लाख में बन गया
Give me the stroke again. Before I think the gross one. All right. So give me the crossword. All right. You're okay.
साफ करके वैसे मतवारी तो वो ये है कि फिर रेजिडेंट तैयार करते हैं पाइप लोग लाइन लगी सारा कुछ लगा 2 महीने का गया होगा आप जिसका सलाई में फेसल लॉक डबल हो उसको क्या करते हैं डबल फेसल लॉक 5 6
I think
मैंने उसको बताई थी अपना जो क्या नाम सुल्तान बाबू वाला काशिफ को हमने सीखी थी उससे ब्रिगेडियर तो ब्रिगेडियर मेजर जनरल तो स्पेस में जाते हैं पैसा जो होता है आपका डिस्ट्रैक्टर नीचे तक डाल के उसको खोल के ऊपर खींचते हैं कड़क करके निकल आती है मैं 3-4 मीटर निकालती हूँ जाना नहीं पड़ता आप सामने से डिस्पोज खाली करके अच्छी तरह आप जो है उसका जो डिस्ट्रैक्टर डालते हैं नीचे डाल के बिल्कुल खोले दोनों नीचे फुल खोला खोल के थोड़ा ऊपर से डाल कड़क करके क्लिक की आवाज आती है दोनों वो आर्टिफिशियल पलटो नहीं हम लोग बहुत मैं ट्राई करूंगा आपके अच्छा APDF किया आपने डिस्प्ले इसके सामने आपने नीचे जहाँ डाल डाला तो अगर इकट्ठा नहीं निकलता तो आप दोनों साइडों से बाजी बाजी करके डाला फुल खोला फुल खोल के जरा सा बाहर करके दिख रहा है ऐसे तो पता पड़ जाएगा बोलते हैं ठीक कर गया साथ में मैं क्या था मैं आऊंगा देखने कभी तो मैं आया नहीं जाता और फिर तो कुछ करने की जरूरत नहीं पता मैं कहते हैं मैंने फिर जब भेजे थे फोटो करने के बाद मुझे अब होता क्या हुआ देख सकते हैं और सही होता है
Let's copy your question. I normally do 3 or more of them. I just put one figure of them, 3 or more of them. What do you call it, Rose? You can call it Discectomy is single white. I do that as well when I want. If it's for a front patient, the main thing is that the integration of the stem is very important for bacon. Because the disc is hard, so it is difficult to remove. It will remove with the piecemeal. That will take a lot of time. So this was a hard disc. This was hard disc, and that's why I have to call it piecemeal. But I think it's all that. The disc is all out and it's with the compression of the patient. What I would do at the end is I would inject some steroid as well.
360
Through the cannula, I will put that needle inside, and then I will inject steroid. Some of it will come out. We already took it out.
Double visit loss. ये जब आप इसमें जाते हैं ना जब खोलते हैं तरह से कहते हैं ये क्लिक करके
I use it at the end of the day, don't have pain and they feel better. Of course, I tend to discharge at the same day. Yeah. Good, yeah.
ये तो है वो कंप्यूटर लेवल
It's a small horizontal incision.
12 साल बाद दोबारा हुआ
The skin incision is not the main thing. It's minimal invasive. It's the way how we did it, we did not stabilize the muscles. We did not destabilize the hair. Give us a small syringe. Syringe. 10 cc. 5.
1349. तारिक साहब का 6 साल का हो गया 10 साल हो गई थी तो मेरी पॉलिसी में फ्रैक्चर हो गई थी हम हिसाब से मैं सीनियर हम हिसाब के ऊपर नंबर था यासर सरदार
One third of this is moved to irrigation. We've lost some of the disc, but still you can see there is a good amount. Okay. Okay. This space, this material, there is a bit of water there. It's got blocked because of the this. So it's unblocked a bit. But it's a good amount of this, you can see. Good. Look, I'm quite often right after today I'm not like that because I was not working. You were like.
ये सर जी शायद 9 बहुत हुआ जाए Excellent job, जी बहुत आला great job, you have done great job.
Hello. So the session has ended and now we are headed for the lunch break.
Thank you very much.
हेलो 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 चलेंगे अमरान भाई लंच पे यार
I'm ready to go. Okay, so injections. I do a lot of injections. Maybe I do myself about between 3 and 350, 400 injections a year. I do really a lot of injections. I like to do injections because I use them for diagnostic purposes, but quite often I do just for pain. Quite often before I operate somebody, I would inject them first. The reason for that is first that I will support my diagnosis like that with diagnostic injection. Second, for me, very important is because I am doing the injection, I see how the patient is reacting. Something happened. I don't know what happened. Okay. Snow in Texas, the movie. So I like to see how the patients are reacting because like that, you have an idea how the patient will be reacting after you operate them. And sometimes, although there is an indication for the patient to be operated, you don't want to operate them because if they are, if psychologically, you know, we talked lately about the biopsychosocial model of the disease. You know, there is a biological part, which, you know, you see different things. There is a psychological part. So basically the patient's behavior, the patient's mindset. Sometimes, although there is indication for surgery, you might avoid surgery because another way to say if the patient is crazy, going to avoid to operate because that's going to cause more problems for you and for the patient as well. And then sometimes there is also social issues. Patients are chasing secondary gains and all that. So it is good to have an idea, you know, like a trial run, which is the injection. So different injections. You can have different injections based on the level that you're injecting. You can divide the injections based on the object that you're injecting, like facet joints, epidural injections. You can have, as I said, therapeutic, diagnostic injections. You can have blocks for anesthesia. So cervical facet joint injections, relatively easy to do. You just go at the isthmus. It's unvariable. The branch of the nerve that you have to block is there, and you're going to hit it. So cervical injections are relatively easy to do. With the thoracic injections, a bit more difficult, a bit more complicated because of the variable nature of the position of the nerves. But luckily, we don't need to do them so much. In the rare occasions when I had to do them, it was I was having some results. I use the same technique. I inject up and above the base of the TP, like in the lumbar. But right, so lumbar injections, facet joint injections are the injections that you probably will do the most. Not difficult to do, but you have to know what to inject. You can see that every facet is receiving a nerve from above and from below the recurrent branch. And so if there is two ways to do the injection. One way is to go straight in the facet, as it is depicted here. So you go inside the facet and inject inside the facet. Or you can inject here and here at the base of the TP of the vertebra above and below, and like that you block the level again. So my preference is on the left hand side. So you go and I go normally and inject the upper and the lower branch because quite often when the injections are done, they are done for somebody with quite degenerative facets, and it's very difficult to get inside the facets. So I prefer that one. Again, the X-ray acquisition, I've spoken about this many times, so just make sure that you get good pictures and make sure that you understand what you're looking at. You know, you have to understand where is the facet, where is the TP. So at least some basic things that you have to. Some people do the injections in an oblique fashion, so-called Scotty dog position. So you can see the dog-like picture here. That's why it's Scotty dog. They check with contrast to make sure that they are in the facet cleft. I personally don't do that. As I said to you, I do up and down, simply because in that case, you can see that. So on that side, it is okay to get inside the facet. You probably can get it, but you can see here that overgrowth of the facet is going to stop you from getting inside the facet. So it's going to be very difficult for you to get inside the facet. So that's why I, by default, I prefer up and down. If you want to do a diagnostic injection, you have to be very careful with how much you're injecting. If you inject more than you are supposed to do, more than 1 mil, usually will go all around, and so that will spoil the diagnostic effect of the injection. But if you're doing it for pain, you can be a bit more, you can inject a bit more. So transforaminal epidural injections. In order to do transforaminal injections, it's a bit more complicated. You should know the anatomy of the foramen. You should understand the anatomy of the whole spine, not only the foramen. You should also be possible to corroborate the anatomy of the spine with what you see on the X-ray. You have to be possible to see and tell on X-ray what is the TP, what is the facet, where is the spinous process, where is the facet, etc., etc. So it's important, again, a proper acquisition of the images, and like that you're going to be precise of what you're doing. So this I mentioned to you when we were commenting on the on that case that we did. So this is roughly what you do to establish where is your entry point when you're doing these endoscopic cases. Remember, you start with the needle, that long needle, and you stick that long needle inside the foramen. So you can start doing that if you would like to start doing endoscopic transforaminal. A good way for you is to start practicing that trajectory by doing injections. You have to get a long needles. I personally got a 16 centimeter long needles, and I perform my transforaminal injections with the approach that is similar to the transforaminal endoscopic. A few benefits of that. Number one, even if there is a very stenotic foramen, I'm nearly 100% sure that I will get inside the foramen with that technique, because you go laterally and you're in an orthograde direction to the foramen. That's number one. Number two, so that's a good benefit for you and for the patient, because you can practice something, and also that's going to help you to transition faster if you are planning to do transforaminal. If you have noticed, I stick the needle and I was already nearly there. And then with the second reposition, I was already in the foramen. That was not like that when I was starting. You're going to spend half an hour to dock your needle at the proper point. That's not happening that easy in the beginning when you're starting. And this is a way to make that happen and to start practicing. So biplanar awareness is very important. Oh, before I continue, I just wanted to comment again. So there is two triangles. You can go in the medial triangle, and you can go in the lateral triangle. So if you are with the normal offset, which is usually 4 or 5 centimeters, you cannot go in the medial triangle. You're too steep. So you will be invariably in that lateral triangle. So with that lateral approach, which is basically between the two lines which we were discussing, the supraspinous line and the suprafacetal line, that's the green area. Then you invariably will be possible to get inside the foramen. And then that's the red area. Remember, we said you don't go below the suprafacettal line, because if you go below that, you're gonna go inside the abdomen and you may damage abdominal organs. So just be careful with that. So biplanar awareness, this is the two planes, usually AP and lateral, the way you follow your needle. And so you know what should be your final position. So this is the final position of the needle on lateral, on AP. So remember, we were discussing about the medial pedicular line, and this is the posterior vertebral line. So on AP, this is the end point of your needle if you would like to do ejection in the foramen or to start endoscopic. And this is the lateral, the end point in the lateral. So this is wrong. You can see here on AP, you are you're just on the medial pedicular line, but on lateral, you're too much inside. So you're inside the disc here. You've gone too steep. That will tell you that you've gone too steep with your trajectory. And that's why you're inside the disc here, not inside the foramen. So here, the tip of your needle is inside the disc. That would be a good position if you want to do discography, but it's not going to be a good position if you want to do transforaminal injections. So this is even worse. Here, see on lateral, you're on the posterior vertebral line, but here you're past the medial pedicular line. So here, clearly, you are inside the dura. So be careful. So you're inside the dura. This is even worse. Here, you've been so steep, so you've gone inside the abdomen. So that's also another dangerous position. So this is what you have to see on AP and lateral. And then when you check with the contrast, you have to see this nice epidurogram of the nerve roots. If you see something like that, that's not good. So you have to back. You've gone inside the dura, so you don't want to inject the contrast in the dura. So this is the planning that I do normally. So see, this is what you would normally do when you do your regular injections. So this will be the traditional technique. You go for 5 centimeters offset and you do your injection. And this is what I started to do in the beginning when I was transitioning to the transforaminal. So I was doing all my transforaminal injections with that lateral technique. And this will be the standard needle. I managed to get this big needle, which is 16 centimeters, and that is possible to do with this technique. Cervical epidural steroid injections, relatively easy to do. Usually you go interlaminar and you use that loss of resistance technique. It's relatively easy to do a procedure. Yes, there is a slim chance of complications depending on what you're injecting. I don't do that myself. In cervical, I do transforaminal again, and I do the transforaminal in AP and oblique. In oblique fashion, I enter the foramen. The patient is supine, and the head is turned away from the site I'm injecting, and I have the X-ray in oblique fashion, 30 degrees. So like that, the foramen is in an orthograde direction. And then I try to slide the tip of the needle on the superior articulating facet. Why I'm doing that is because here you'll have the vertebral artery. And then once I'm in, I confirmed with AP. So on AP, again, it should not be medial to the pedicle. Otherwise, you can inject inside intradurally, or once you put the contrast, if you see visualization of the vertebral artery here, then again, you have to just pull the needle a little bit back. Just to remind you, if you're doing cervical injections, just be careful what you are what you're injecting. I would not inject the post-steroids because the particles are too big and you are risking embolism. So dexamethasone only for the cervical injections. You can do injections also for back pain with discogenic origin, but in that case you have to address also the sinovertebral nerves. In that case, you can inject the facets, but you have to do intraforaminal injection as well. And I think that was it from me. Thank you. Any questions? Yes.
What's the severity of the transforaminal epidural injection versus the epidural?
So with the transforaminal, you can be more precise. You can use it as a, so you can do interlaminar epidural. Yes, you can do that, but you would use that mainly for pain, to alleviate pain for somebody. But let's say if you have a case when somebody 70-year-old coming to you with some radicular symptoms, but they are not very clear. They don't talk so much to you. They cannot explain to you. You cannot make any radicular symptoms, a specific dermatome. You cannot make it from what he says, from examining him. You go and see his MRI scan. You see multi-level degeneration. So you wonder, where is that coming from? I have to operate, but I don't know where to operate. Do I operate all this level? Do I operate one single level? In that case, you go and do transforaminal and you inject a small amount, like 1 milliliter only, and that is pure diagnostic procedure. So if you do that, and if the patient tells you, oh, I had significant improvement on my symptoms, this is your level. You have to go there. I do local and steroids. Yeah, in lumbar and thoracic, I usually will mix depomedrol or some other depot steroids with local anesthetic. Usually will be 0.25 carocaine. I don't go above 0.25 carocaine or marcaine because if you use stronger concentration, you can block the nerve, you can block the motor part of the nerve, and then they will be paralyzed. You have to keep them, you have to watch them for a couple of hours, nothing else. Yes, I do caudal blocks just for pain. Yeah, this was actually one of the first injections that I started doing in my practice. Yeah, I can. So with the caudal block, you can just, if you do caudal epidural, you can prepare a 20 cc mixture and you can slowly inject it and it will go up to L1, L2. So basically, if somebody like that same guy that has, that is 75 and he has multi-level degeneration, he has a lot of pain, he, however, has a heart disease, he has lung disease, you cannot operate him. You want to do something for his pain, you want to keep him going, so you just do caudal epidural, big amount, 20. I would mix 80 milligrams of depomedrol with 10 milliliters of 25 marcaine plus 10 milliliters of normal saline, and I'll inject all that. So I will give him good pain free for a period of time.
So what's the anatomical gate blocks, an arm of Iraqi surgeon. So this procedure, he inject lidocaine plus normal saline.
Where?
In the epular head or the sciatic bag.
I'm not aware of this. I'm sorry, but you can please, if you have information, I'm interested. Send me.
Yeah, well,
please send me that. I'm interested.
I just experienced this with severe pain, just sleep within 5 minutes.
Okay, never heard about this, but I'm interested to read about it. Please send me that.
Few pain management people are telling us not to use particular steroids. This is very dangerous.
Okay, I use that in lumbar and thoracic. I don't know why. I use it and I have good results. Yeah. 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 In cervical, I use dexamethasone only for pain or for anything. In lumbar and thoracic, I use particular, and I have no problems.
Radius formation, we use particular steroids. According to them, there is more radius formation.
I have heard these theories, but I have so far. I told you I inject many of my patients before I operate them. Sometimes I manage. Some people, they are reluctant to have operation, so I have not one or two cases when I manage them with injections for a while, and I use these particular steroids, and I go then and operate them, and I don't see adhesions. Well, you have to analyze the clinical symptoms and you have to see the MRI scan. So if you see nothing on the MRI scan, really nothing, sometimes you don't see a disc herniation, but you can see, let's say, disc degeneration. You can see internal. I had recent case just recently, somebody who the first look was somebody who young, 45-year-old man, fit and well. So he presented with back pain and also quite significant L5 pain, significant, very, very defined L5 pain. So the MRI scan, the first look is there is no disc herniation. There is a bit of a black disc disease at L5S1, but then a bit more careful analyze. And then we saw that there is an internal disc disruption that is laterally located, and it was exactly in the foramen of L5. So you see that whiteness there, just next to the L5 nerve root. And although there is no massive disc, there is a chemical moment there as well. So that's irritating the nerve. And so this guy was very, very symptomatic. So he benefited with injection well, and then he settled.
On an angulated line.
Say,
when we mark an angulated line, and we should put a needle inside to reach our destination. So how deep we go? Is it in subcutaneous plane or is it more deep to prevent the abdominal?
So when you're doing your first injections, when you're using that technique, you will be you'll not be like the way I did it today. I did it today, just I put it there and then it was exactly where I wanted it to be. This is probably because I have done a few injections before and then I know roughly where is the trajectory. But if you're developing that skill, you will go through a few more pictures. First you're gonna have this situation. Then you advance a little bit, again, you do AP lateral. So like that, you slowly advance and then you do the necessary corrections. This is the way to do it. You can assess the depth on lateral. Yeah.
So you have to correct, you have to see both pictures simultaneously. Yeah. Otherwise, you will go deep.
You always follow the tip of your object on AP and lateral. That's the safest way to do. And the less experience you have, the more pictures you will need to follow it. Yes. Say again, please. I don't curve the needle. I know that some people are curving it a bit, so they use that curve to steer the needle. For me, usually is enough just the bevel. So I rotate the needle. The needle has the bevel. So if I rotate the bevel, the bevel usually is giving me a few degrees correction, and I'm okay with that.
Some people injection.
For?
Transforaminal injection.
Yes. So Scotty Doc is mainly for the facet injections to get inside the facet. Yes, you can use it for the foraminal injections. I don't do that. I use AP and lateral straight. Trigeminal. Yeah, well, I do that, but I do that very rarely. RF as well, yeah. Okay, I think we will give now we'll give to Onur to show us a few cases. Classification is usually going from 7.5 centimeters.
So my topic was vertebroplasty, but we have changed it. So for adult degenerative scoliosis cases, what we have to do. So if you want to correct a patient like that, it was before the surgery and after the surgery. So first of all, we have to know that also this was another case that has a adult degenerative scoliosis with corneal imbalance. So the question is that are they what we're treating? Are we just treating the pain? Then the Nicolas techniques are very well to solve the solution. Are we just looking at the deformity or are we solving the pain problem? I think the main question is that. So there was a case like that. He was 65 years old, a male, has back and leg pain, and had a pain. The pain has started just 1 week ago. So if you look at the walking here, he was walking like that, but before 10 days ago, everything was fine. So if you look just at the X-rays here, you may see there is a scoliosis there and the patient SVA has increased. So what we're going to treat here, the deformity, if you look just at the X-rays, so you'll say that I have to start from T10, I have to start at S1, I have to go to the iliac wings, I have to do pontiocyotomies here, but you have to solve the pain problem. So there was only a disc. We have operated that patient with dynamic instrumentation. And if you look at the preoperative and postoperative films, we have corrected the deformities because the deformity was just due to the pain, because everything has started just 1 week ago. So there is another case here, 55 years old, male with back pain. Everything has started 2 weeks ago. If you look on the X-rays, if you look the SVA, you may say that I need a pedicle subtraction osteotomy here, but the problem was just a disc, and if you remove the disc, you will solve the problem. This was before and this was after the surgery. So we have to analyze the films, okay? The films has a language, we have to learn that language. There are lots of parameters that we have to learn, but we have to know the methodology. So in the middle part, this one, do we have a pointer? Sorry. The film in the middle, there is no problem in that patient, but on the left side, everything is clear. The patient has a sagittal imbalance, but this patient is important because everything seems that everything is normal. The patient is balanced. The patient is balanced because the patient is using the compensatory mechanism. He has increased the pelvic tilt. Because of that, it's covering something. So you may say that there is no problem. Yes, this patient has a sagittal imbalance. This patient has also problem, but he has using that compensatory mechanisms and she can balancing himself. So these are the problematic cases. Where do we have to stop? Where do we have to start? The main question is that we are using Veriano-Lamarck classification. This is type 1. It's far away from the apex. If you just solve the problem at the that point that I've shown you in the first two cases, you will solve the problem. If you have more problems at the apex, just fusing that levels will be enough. And if the patient has more than 4 or 5 levels, you have to just fix that levels. But the main problematic cases are the type 4 cases that have sagittal and also corneal imbalance problems. So we have to learn the sagittal balance methodology, because these are not just numbers. These are the things that we have to aim during the surgery. After we have finished the surgery, these all parameters has to be under the limitations. So there are lots of parameters. I passed this parts. So corneal balance is also another important point. You have to also balance your patients. So to solve this case, we are using the surgery map software. So the patient, beginning of the surgery, okay, you have to say your patient that the complication rate will be 40%, okay, 40. And half of your patients will go to the revision. These are the great numbers for adult degenerative scoliosis cases. So to correct the sagittal balance, you have to need osteotomies. At the first day, we have talked about that. How do we decide the level of the osteotomy and how do we decide the type of the osteotomy? So using that softwares, we're just applying an osteotomy at the L4, a pedicle subtraction osteotomy. We will see if it works or not. Applying an L4 pedicle subtraction osteotomy will not work for that patient. So we're trying different osteotomies, adding ponte osteotomies. Just one ponte and pedicle osteotomy will not work for it. Plus one ponte osteotomy, it also will not work. So we have changed the type of the osteotomy. We have applied an corner osteotomy. So if you have the chance not to add the S1, don't add it. But if you want to correct that spine, adding a, let's say, L3 corner osteotomy will not help you. You will rescue the S1 because you will need 2 more levels. Imagine that you're doing L3 corner osteotomy here. You may rescue S1, but you will not correct the spine as much as you want. And the L3 pedicle subtraction or corner osteotomy will be not physiological because the apex of the lumbar curve is below the L3. So you have advantages to come to L4. You have the advantage you can correct more and will be more physiological to the lumbar lordosis, but you have to add S1. So at the end, we have decided 2 double ponte osteotomies and L4 corner osteotomy. So this is a pre-bending route. We have decided to start from T10 to iliac wing. We have bended that route before the surgery. So it helps you not to spend any time during the surgery, and you just put your route during the surgery. You will know that this is a proper lumbar lordosis. These were the pre-bending or custom-made routes. So during the surgery, you just put it inside and you get 2 X-rays during the surgeries. You will see that you will have a good lumbar lordosis. This was our plan before the surgery. Look at it. We were aiming to have there is the lumbar lordosis here. It's 39 degree. So during the surgery, we have measured it. It's 33. It's less, but it works. So this is after the surgery. The plan before the surgery, after the surgery. This is the last case. The patient has back pain and bilateral leg pain, bends forwards in time. These were the sagittal parameters we have measured before the surgery. So you have to decide which level, which type of osteotomy that you're going to apply. So it was L4 type 4 osteotomy at the L4 level. We have removed the disc. We have removed the pedicle here. We go just to the upper disc. We have also removed the disc. We have applied the interbody cage. Corner osteotomy will give you a chance to correct it 40 degrees. So this is after the surgery. So thank you so much for your attention. Do you have any question? Yes.
Certain population from 10 to 12 year of age, patient presents with deformity, and when we do workup, they turn to the teeter guards. We release the teeter guard, but should be the next step.
You can correct every deformity, okay? The answer is basically like that, but the patient and the relatives have to know that it's really a complicated surgery. I'm talking about adult degenerative cases, okay? 40% you may have complication and half of your cases will need revision, okay? The question is, I think the main question has to be like that. Are we treating the pain? Okay, if you're treating the pain, the minimal invasive techniques are the best solution, I think. The injections or the minimal invasive endoscopic discs methods are the best thing, okay? But if you're trying to correct the deformity, if a patient says that, I don't want to walk while I'm bending, I want a new shape, okay? Then you have to do big surgeries like that. So some of my colleagues says that I'm doing lumbar spinal stenosis, okay? I have enlarged the channel, okay? But they put screws inside, okay? So the question is that why are you putting that screws? We're talking, you have to start from T10, you have to come to S1. Then most of the colleagues are just inserting a rod in this shape, okay? So you're starting a deformity without knowing these parameters, okay? They're just bending the rod for 10 degrees. They put a straight rod inside. So we are beginning a deformity. So if you're not solving the problem, so at least you don't have to start the problem. If you're doing lumbar spinal stenosis, there are lots of ways. Minimal invasive, unilateral approach, bilateral decompression. Don't put screws. If you put screws, you have to know the basics here. Okay, the second question, congenital is totally different, okay? So as neurosurgeons, we are just dealing with the tetrad cord or the intramedullary pathology like the diastematomyely, but we leave that chance, okay? For 5 years later, they're coming with severe deformities. We are neurosurgeons, we are dealing with the spinal cord, we know it. So we have to learn the deformity, especially the congenital deformities. For a while, we have to need time to patients to grow up, okay? But it doesn't mean don't do anything. You have to solve the main problems, the tetrad cord or the diastematomyely. Then we have to apply some friendly growing techniques. When the patient is coming to 10 or 11 years old, the maturity of the chest will complete 80% of it. But when the patient comes to 13 years old, the maturity of the chest will complete. If you do a final surgery before 10 years old, the patient chest will not grow and the spine will not grow, okay? But if you let that patient to the prognosis, the natural prognosis, it will progress. So at that patients, we have to use the growing friendly growth techniques, okay?
Regarding your first question, sometimes the temperature of the deformity is like that, it maintains the sagittal balance. I was asking in that scenario.
You're talking about type C, okay? The answer is again the same. If the patient has not coronal or sagittal imbalance, it's a type 3, then you have to include the end vertebras, and let's say it's starting from L1 to L5, just finish it there, okay? If the patient's curve is larger, you have to pass the thoracolumbar junction, but try to keep not to come to S1 because it's really a problem. Okay, there are lots of cases here. Look, we have corrected many cases. Can you show the slides? Sorry. Sorry, brother. Can you show the slides? Look, there was a case. The patient has sagittal imbalance. We have corrected it. Then after that, we have loosed one of the screws that we have applied here. Then we have another revision surgery here. So we put an extra rod. We have distracted it. We have a good coronal balance here. This is kickstand rod technique, an extra rod to the iliac wing. We put an extra rod here. We distract it. We bring the spine to the medial part. This is the technique that how we apply it. This is the cranial part. This is the caudal part. I have revised this case 3 times. So let's make it a bit faster. This part is the iliac wing. We have changed the position of the iliac wing. Then so the maneuver is like that. You have to use a strong rod holder. We have fixing the iliac screw head. We're loosening the head screws here. Then this is the rod holder. We're just distracting it. It's coming to the midline like a tree. So when you correct the coronal plane, you're losing the sagittal plane. Then you have to use an extra rod to balance the sagittal plane again. So when you start the surgery, you have to do the revision again and again. Any other question? Yes? Look, I have it on my computer here, but it's not seen here. I have a software here, SurgiMap, okay? But I put the films on the SurgiMap. It's free, yeah. Before the surgery, I measure everything. So I know which I have to correct. I have a plan before the surgery. I'm not deciding anything during the surgery. Okay. Intraoperatively. Yeah. I showed it. Let me show you again. I'm using pre-bending rods, okay? Like this case. Look. Can you show the slides again? This is intraoperative view, okay? I get 2 different X-rays here. I get, because you cannot bring all the vertebrae in the same shot, okay? So this is L1, this is L4, L5, S1. I bring it during the surgery together on the computer so that I can see what happened. So I measure it. You see the lumbar lordosis is 33 degrees. Another technique we're using is that we're using another T shape I have to see if the spine is balanced or not, okay? I use another extra T-rod here. I put it on the iliac wings, and the rod has to be between the rods here. If it's out of these rods, it means the patient has coronal imbalance. So another trick point here is your L4 vertebra has to be parallel to the floor. If it stays like that, the patient will wake up on one side, deviated on one side. Sorry? Yeah, we're doing it. During the surgery, we just... Oh, we don't have it. We just... Yeah, if you have it. If you have the option to do the scoliosis graft during the surgery, it's perfect, but we don't have it. So I just combine it during the surgery. Look at the films. These are 3 different C-arm shots here. Okay, one is at the thoracal area, the other one is the lumbar area, the other one is to the iliac wing here. I'll just combine them. Any other question? Thank you.
Assalamu alaikum. Okay. The topic given to me is about pedicles. Basic topic. It's like a revision, quick revision for our young doctors. Okay. Nothing very fancy in it. Animation हो रहा है Yeah. We know that it's short, thick processes that projects posteriorly from the vertebral body between the vertebral body and the transverse processes. The functions encase and protect the spinal cord. Nerve roots serve as attachment points for various ligaments, muscles, helps in maintaining stability. It gets on bigger as we start from cervical spine, thoracic, then lumbar, along with the vertebral bodies. All the things are getting bigger because they have to bear more weight, and this is the strongest part of our vertebra. Okay, and C spine are angled medially and superiorly. Here we can see this angle superiorly and medially. Then if we plan for C2 screws, we normally don't go for C2 pedicle screws, but if we do want to plan it, then we have to have some MRI, and CTA to determine the course anatomy of the vertebral artery in foramen transversorium of C2, and to determine whether there is enough bone width between the superior medial border of foramen transversorium, lateral border of spinal canal to accommodate a safe passage of long C2 screws. Also note the location of carotid in relation to the anterior border of C2. Okay, can we make it a little interactive session? Okay, what we can do if we are not planning a C2 pedicle screws, what options we have? We all do it regularly. And translaminar and what were the old techniques forefathers were doing? Wiring. Good. Okay, why the wiring they give up? Why we are not doing wiring? Any specific reason? तुम तो सीनियर हो बहुत यार, बोलने दो ना बच्चों को. मूवमेंट रिस्ट्रिक्शन वैसे इसमें भी हम लोग कर ही देते हैं, ठीक है. और स्क्रूज जो हम लोग स्टेबिलिटी कर रहे होते हैं, जो स्क्रूज को फिक्स करने होते हैं, वायरिंग में हम लोग पास वो फैसिलिटी नहीं है, ऊपर से नीचे जो स्क्रूज लगा रहे होते हैं ऑब्वियसली, ठीक है. ये C2 के पेडिकल्स जो है वो बहुत थिन होते हैं और आमतौर से हम लोग रिस्क नहीं लेते वर्टिब्रल आर्टरी को टीयर करने का, ठीक है. Okay, entry point superior medial portion of lateral mass of C2 is 3 mm above C2, C3 joint and 3 mm medial from lateral border. Trajectory is medial lateral border of C2 spinal canal. The trajectory should be as medial as possible, but without violating the lateral border of spinal canal, obviously. Medially is 15 degrees, superiorly is 25 degree, depth must be 25 to 30 mm. Okay. So we have to remember these small things. Okay, okay, this diagram shows it all. C1 arch is going C2 pars, and the entry point is shown as written over here. Then the medial is 15 degrees, superior is 25 degrees. Okay. Okay, there's a bigger diagram shows it more clearly. Okay, then the subaxial cervical spine pedicle screws review. Pre-op imaging, steady vascular anatomy is very important. Although foramen transversorium may be present at C6, C7, but it not transfer the vertebral artery, only the veins are there. So it's easy for us to get a screw over here. Okay, entry point is again 2 mm lateral and 2 mm superior. Trajectories consider laminectomy. Safe to have laminectomy. You can feel the screw. I always do laminectomy to feel the screw whenever I'm in doubt. Okay, palpate the medial border of pedicle. This is more comfortable. Trajectory is medially 30 degrees, superior is 0. Depth is 15 millimeter or longer maybe. Okay. Then the subsurface of the pedicle is in line. This is some basic things. Okay, is in line epiphyseal ring of the. What we mean by epiphyseal ring of upper end plate? Epiphyseal ring of upper end plate means? Anyone? कोई कुछ नहीं बता रहा क्यों भाई? Epiphyseal कहते हैं, कुछ याद आ रहा है कि epiphyseal it's a part where the disc is adhered to the upper end plate. Okay, okay. In the upper mid thoracic spine, lower surface of the pedicle at the mid body, then intervertebral foramen formed almost exclusively by inferior vertebral notch. The superior notch is almost not existing. Okay, the main is inferior vertebral notch. Then the lower thoracic spine, relative increase in the pedicle height. Lower surface of pedicle at lower 1/3 of the body. The lumbar spine pedicle positioned little lower as compared to the dorsal spine, more pronounced superior vertebral notch. In sagittal angulation, thoracic spines, pedicle angles caudally and inferiorly to meet the body. But in the lumbar, pedicle coplanar or in line with the body. Okay. Okay, dorsal spine, the entry point is top 1/3 of the transverse process immediately lateral to the midpoint of superior articular facet. The lateral border of the facet corresponds approximately lateral of pedicle. Okay. Obviously, you have to use fluoroscopy no matter how much we know about or in the angles or whatever. And there are some changes always. Trajectories from T1 to T12 and axial planes from medial to straighten. In T1, it is quite medial, 30 degrees, then it is less medial, 10 degrees, and in T10, T12, it is straight, 0 degrees, okay. Again, we can perform hemilectomy to be sure that we are in pedicle. Between the thinnest pedicle, dorsal spine, between the thinnest pedicle in dorsal spine, we all know that. Which level? I think it's T4, T6. Okay, it's the thinnest. We have the pedicle over there. We have to more careful over there. Must do, in my opinion, must do hemilectomy to be sure. Okay. In sagittal plane from caudal to straighten. So T1, T2 is varicaudal. Varicaudal means about 20 degrees, then T3, T10, last caudal 10 degrees, and again T12 and T11 straight. Okay. Okay, we have shown the things over here. Okay, then again some entry points, the variable entry points T7, T8, T9 is and T1, T3 to T3 and then T12. And the other thing is the other method is uniform entry point. I always go for uniform entry points, more easier to remember actually. Yeah. The simple, the 3 mm inferior to the junction of the lateral edge of superior facet and the transverse process. Trajectory, the beautiful thing is trajectory always is straightforward in this uniform entry point method. Okay, here it is shown the uniform entry point method. Okay. And transverse pedicle width limits size of the pedicle screws. Okay, the thoracic spine height is double of the width. Width is smallest at, as we already discussed, T4 and T6. Increases minimally till the thoracolumbar junction. Pedicle rib unit allows more lateral entry. So the B figure is showing the pedicle rib unit coming outside from the pedicle, another method, but I never do it. Okay, so it is their method if we have the damaged pedicle. Okay, then lumbar spine entry at the base of the transverse process, the intersection of the center of transverse process and the sagittal plane through the lateral aspect of the superior facet. If a laminectomy has been performed at level and location of the pedicle is verified by palpation. Okay, the entry point is again the junction of midpoint of transverse process of the superior articular facet. Trajectory from L1 to L5 in sagittal plane is progressively more caudal starting from 0 to 10 degree. L1 is 0, L5 is 10 degree. Then in axial plane, we know there's increase of 5 degrees. L1 is 5 degrees and L5 is 25 degrees. Okay. Same thing is written over here. Okay, then the orientation of facets, it is intermediate between sagittal and coronal in lumbar. Then progression from relatively sagittal to relatively coronal. And coronal orientation at L5S1 prevents spondylolisthesis because we have more weight at the lumbar region. So the facets progressively more lateral from rostral to caudal, articulating surfaces superior and inferior to the inferior, superior facet to inferior. Okay, so in order to prevent the listhesis, okay, this mechanism is must given by nature or God. Okay, thank you. Any question? A good question.
So now we'll be heading towards the workshop. We'll move downstairs where the hands-on workshop is going on.
Yes.